By way of introduction then, so for those of you that don't know me and my organisation, I'm Kash Haroon, Director of Consultancy at Northwest Employers. Like I said before, this is my third one of these, chairing these, so I'm delighted to be and privileged to be doing this again. But I am joined by a very talented, action-packed team. But actually, before I introduce them, let me just share some Zoom etiquette for those of you that haven't used Zoom before. If you can just flick to that slide for us, please, Isha. There you go. So this is how you use Zoom. So everybody will be muted at the start of the webinar, which is what we are doing right now. So you should only be able to hear my voice. But then, if you do have any questions, please type these in chat box. And we've already done some interactions in the chat box, and then we might not be able to answer all the questions straight away, but as we do with these sessions, it's important that we curate it well, which this recording is part of, so you will hopefully see some of the themes coming through. The instructions on the screen are really self-explanatory. That is how you mute yourself, that's how you start using your webcam. And to open the chat box, there is a neat little button there. And for those of you that have used Zoom before, we are not doing breakouts today. We are doing a full-on webinar. Before I hand over to our first speaker, I just want to introduce the 5 partners. So this set of collaborative masterclasses is something that we and partners have been working on for a number of years. I think this is our 3rd or 4th year of doing this particular thing. So I represent Northwest Employers. We are the employer's voice for all 43 local authorities across the Northwest. So we get involved in all sorts of fun things. And my colleague Sharon is here. I don't know, Sharon, if you want to say hello quickly.
Morning, everyone. Good to be here with you. Thank you.
Thanks, Sharon. Next, we've got AQUA, the Advancing Quality Alliance. They're a regional health and care quality improvement organisation. They work across the NHS, care providers and local authorities. So I don't know if colleagues just want to give us a hello and away from AQUA.
Hello, morning. I'll also be supporting the chat box, so really looking forward to it. Thanks, Kash.
Thanks, Louise. Next, we have Innovation Agency Northwest Coast, who are an academic science health network for the Northwest Coast. And they collectively look after innovation across the NHS. So I don't know if there are any colleagues from there, if you want to just give us a quick wave. Okay, and then Northwest Leadership Academy, who provide leadership support to the NHS, and they are a membership organisation as well, and they support a number of interventions and programmes across the region. Northwest ADAS, they're another Northwest level sector-led improvement body, but looking after adult social care. And then we have MIAA, who are a leading provider of assurance services and also support the local government and third sector. I know, Pam, you and the team are here, so I don't know if you want to say hello and give everybody a quick wave.
Good morning. I will also be looking after the chat box this morning.
We are on Twitter, so #CollaborativeNorthwest, and every time we do one of these, we end up having some really good conversations on there as well. As I've said before, we'll be recording the event and linking everything together, and yeah, hopefully there'll be time for questions. So yeah, that is the plan. And actually, with these sessions, you know, we are expecting you to take your own breaks. So if you do want to get a cup of tea, or you know, have a natural break, yeah, that's absolutely fine. Just switch your camera off, and actually, you know, we will be running the event through till 12:30. So that's the plan. Any questions from anyone, or anything that I need to cover from the team? Fantastic. Right then, Dominic, so let's think about the Northwest lens. So to start things off then, I'll introduce you to Dominic. Dominic's been one of the leading voices in the battle against coronavirus. As the Director of Public Health and Wellbeing, we're delighted that he's here with us today to share his work. He's known for being passionate about social justice and fairness, and believes that improving public health inequalities is the best way to improve people's life chances and life expectancy. Something that the pandemic has very clearly exposed. So, Dominic, delighted to welcome you to the group and the session, and handing things over to you. Thank you.
Great, thank you very much, Kash, and hello everyone. So I'm going to say a bit about, I want to tell you a story about the enduring transmission impacts of the pandemic on the Northwest, and I will be using Blackburn with Darwin as an example, but of course one of the ways to think of this is Blackburn with Darwen actually has the highest cumulative case rate of COVID in the UK. So we've had the most people infected. And I'll say a bit about that. But of course, everything I'm going to say is probably true for most of the local authorities in the Northwest that have high levels of inequality risk, and most of the small areas in otherwise wealthy authorities that have high health inequality risk. So I think that's the context in which I would like you to take what I'm going to say and some of the evidence I want to give you. I will also say a bit in advance of Jane's session on systems, because I think this is going to be critical for us in addressing health inequalities into the next 2 years. So I want to say something about that. So just starting off then with enduring transmission. In December 2020, the Joint Biosecurity Centre wanted to understand why some local authority areas in England were experiencing much higher rates of COVID than others. And they picked a number of local authorities, Leicester, Bradford and Blackburn with Darwen, who at that time had consistently appeared in the top 5 case rates throughout 2020. And what they did was they set up with us a set of potential hypotheses of why we were getting a larger case rate. And as the piece of research developed, the term high and enduring transmission areas became the one we focused on. There's different ways to describe it, but that seems to have stayed. They looked at the data and the evidence across those local authorities and tested the evidence against the hypotheses and were able to confirm or were unable to confirm some of the hypotheses. And broadly speaking, the factors that came out from the research, which were evidenced, were that a number of structural social inequalities and infrastructure inequalities were driving higher case rates in those local authority areas. And of course, the first thing to say they found was that those local authorities that entered the pandemic with more cuts and with higher demand on their public services were also more at risk of higher rates. They found that areas that had low income and precarious employment had a much higher percentage of the population out in frontline work in the NHS, in social care, in transport, in food production, and those communities were unable to lock down during the various measures of control, including stay-at-home advice. And so we're much more regularly exposed to whatever the circulating rate of the virus was. And of course, since then, ONS have confirmed that data. So ONS looked at what percentage of the population in different local authority areas were able to work from home during the whole of 2020. Areas of East Lancashire had about 18% who were able to work from home. Richmond-on-Thames, as an example, had 73% of its population who was able to work from home. So that difference in risk exposure was a main driver of increased COVID risk. Many of those local authority areas, like Blackburn, had larger families in smaller houses, and of course some of those were extended BAME ethnic minority families who had older relatives in those houses. And of course, as transmission was often introduced into the household with often an asymptomatic young person infecting the whole family unknowingly, we got a much higher rate of household transmission. So at the peak of some of the waves in 2020, many local authorities in the Northwest had about half of all their cases being household transmission. And that was an amplifying effect of whatever the circulating community level case rate was. So people were getting it from their family rather than initially from, walking around the supermarket. On top of that, the government in policy on international travel generated risks. I mean, this was slightly later than the enduring transmission work with JBC, but of course the Delta variant was introduced first into the Northwest by travellers returning from India and self-isolating in their homes within the local authority rather than quarantining. And India should have been locked down, should have been red listed 3 weeks before it was, because India had higher case rates and India had identified variants, which Pakistan and Bangladesh did not. But nevertheless, India was not red listed until 3 weeks after Pakistan and Bangladesh. So in April 2021, of course, we got the Delta wave before everyone else in the Northwest, first Bolton, then Blackburn with Darwin. The way the enduring transmission work has now been framed is that firstly, the government refused, JBC and PHE refused to publish that research. It's not in the public domain. They refused to publish it. They did say that it would be used to develop policy. And they have promised that, well, we've heard through various leaks that 20 local authorities will be offered enduring transmission support over this winter. And they will be offered a mixture of increased resources or increased permissions, for instance, for policy changes, in order to keep the spread of coronavirus low over the winter and protect the healthcare and healthcare system and the population. Now, we haven't had that offer. It's meant to arrive to those local authorities chosen as an offer letter, but it's still, we understand, stuck in the Treasury for various reasons, so we haven't had it. Anyway, so that's the enduring transmission story, really. So structural, social, economic, and some demographic determinants presenting much higher risks to some areas across the UK. Now, of course, one of the things we have seen since the Northwest in particular got hit in the first wave of the pandemic, if we think of not the first wave of cases, but we think of the pandemic in two halves as probably going up to June this year, so after the Delta surge, the Northwest definitely had higher rates. Many of the local authorities were in the top 10 for most of that phase. Of course, as from the summer onwards, we have had slightly lower rates as a region than the rest of the country. And part of the thinking of that is that we have an extra level of protection on top of vaccination protection, which is infection-acquired immunity. So we have a much bigger percentage of our population who've already had COVID and who have some natural immunity from that, which is an extra layer of protection. However, so we have had lower rates generally than the Southwest, for instance, since the summer. But one of the things that prolonged pandemic impact has done to our region has meant that less people were able to get routine care in primary and secondary settings over the 19 months of the pandemic. So we now have longer waiting lists. Not only do we have longer waiting lists, we've got more people who were not, for instance, regularly screened for high blood pressure. And over 19 months, that means quite a big percentage of that population is either suboptimally on suboptimal medication, or they simply haven't, they've moved into high blood pressure over the last 19 months and haven't had that diagnosed. So we do stand an increased chance of a surge of heart attacks and strokes over the winter, particularly in the cold months for that reason. We've also got much more pressure on our secondary care system. Research, well, data published by NHS England show that we have less GPs per 100,000 of the population in many of our poorest communities and many of our communities most impacted by COVID. So Blackburn with Darwin, for instance, has the 7th lowest percentage of GPs per 100,000 of the population. And we've had in the last week, our hospital in Blackburn, East Lancs Hospitals Trust, had 3 times the number who would normally turn up to A&E turn up last Wednesday. And they would have called a critical incident, but I think they got a bit of pressure from NHS England not to call it in that way. But basically they were having to ask people, unless it was urgent and emergency care, not to turn up on that day. Now, I think we are going to see a surge in, well, we are already seeing a surge in non-COVID winter pressures that will create excess winter mortality. So next slide, please. Part of the context of the Northwest hit, of course, is that we entered the pandemic, and this is data really from 2017, so this is pre-pandemic, with by that time 7 years of consistent cuts to local authority services. So this is all the local authorities in England. What percentage of cuts to their core budgets did they get by 2017? And I mean, that red arrow is Blackburn with Darwin. Many of the authorities that had the biggest cuts, up to 50% by 2017 even, were Northwest local authorities. And of course that disabled us from being able to resource some of the interventions that would have been protective in the event of a large-scale pandemic, and reduced core service provision across all of our services, including those services that were critical to supporting communities to address social determinants. Next slide, please. Now, back in 2010, as the Conservative government came in, many of the publications and research that was done by the previous government were taken offline. One of those pieces of work was this, which isn't available online, but I have a copy, which was the Cabinet Office was asked to review, as a response to the financial crisis, what evidence there was about recession causing harm. And so they looked at all the research back to 1900 about likely impacts of a financial crash. And what they found was convincing evidence, consistent evidence, that most financial crashes came in 3 waves. The first wave was the obvious economic impact, with job losses, reductions in household income, falls in property prices. Then they argued there was a second wave, the social impact, increasing family stress, mental health problems, increasing domestic violence, rising crime, increasing alcohol addiction, etc. And then there was a recovery phase, but the recovery phase was evidenced as inconsistent with those local authorities who entered any economic recession with a worse record of employment, etc., were much slower in exiting, and some actually never exited and stayed in the kind of impacts that are identified in the social impact there. Now, what we know, of course, that research was published in 2009. What we know is that everything that was predicted by that research in 2009 has actually been going on since the first financial recession. All those indicators in that social impact list have actually evidenced, can be evidenced as happening. And again, some of that was brought forward into the state in which many local authorities was in before the pandemic. Next slide, please. The Cabinet Office research suggested the solution was that we need to recapitalise vulnerable communities, and they identified 4 capitals that were critical: mental capital, financial capital, human capital, and social capital. And a lot of the rebuilding, levelling up, building back better, I think still needs to take account of this research on economic recessions. Next slide, please. Now, the NHSA has done quite a bit of work on the impact of the pandemic on northern powerhouse areas, so not just the Northwest, but many northern economies. And I know many of you will have seen this research, so I won't go into all of the detail, but that the impact is well documented. And of course, part of the conclusion of this is that what we are going to need to do if we want to build back better, both economically, socially, and in terms of health and health inequalities, is consider an investment in recovering health and well-being in the Northwest to enable it to at least get to the England average, and particularly in terms of long-term conditions. And that is probably the best investment we can make to recover economic well-being across the region. Next slide, please. Next slide, please. And in order to do that, NHSA have set short, medium and long-term priorities, many of which I think will feature, I know, in all of our recovery plans. But of course, many of those will need both resources and often policy permissions, greater powers at local level to make decisions. One of the ones, for instance, in relation to health inequalities, just goes back to the enduring transmission issue, which is the Northwest and many of our poorer areas have some of the worst housing in the country, pre-1919 terraced housing, often with high percentages of South Asian mainly, but not only, families in. Many of those are rented by private sector landlords, and many of the powers we might need to improve the housing standards in those houses, many of which are below decent home standards, are not available to us legislatively. We cannot legislate to control some of the ill health effects from some of that housing. So powers, for instance, would be, as well as resources, can be very important in addressing social determinants of health. Next slide, please. Now we are going to, if we want to build back fairer, look at not just those wider social determinants, but actually we are going to need to look very closely at the health and care system, because of course, although most of the drivers are social determinants, 80% of the things that are causing risk are social determinants, most of the things that will stop people dying unequally in the next 2 years are probably going to be to do with the NHS and social care system. So there's a bit of a paradox there. Next slide, please. In 2015, we had one of the highest spikes in mortality of any month since World War II. And that spike in mortality was researched, which I was involved with colleagues. Next slide, please. And one of the conclusions was that basically over the winter of 2015, the health and care system was simply overwhelmed. It had had sustained cuts. It had very high sickness absence at that time, and it also had very high vacancies. And just as an example of what happened, this is not the mortality, but this is the number of patients spending over 12 hours from decision to admit to admission. And if you look at that spike and compare it to the rest of the 5-year average, you can see exactly what was going on in January 2015. Basically, every bit of the system, including 111, ambulance, the GP, ambulance, hospital, all delayed admission because of the pressure on the system, less staff, vacancies, more people needing urgent care. And of course, what happened was, as people who were close to death were being admitted, the delay in admission caused the excess mortality. But the reason was not any single institutional failure. It was a failure of the whole system to be able to mobilize appropriate urgent and emergency care for the population. Now, I think we are going to get over this winter a spike that is potentially bigger than that in terms of mortality, in terms of lack of capacity in the system to treat people who require urgent and emergency care. Next slide, please. So this is some of the signals we're already getting. So this is overall COVID deaths and excess mortality, looking at the Northwest England and Blackburn with Darwin. So if you look on the right hand side, which is excess death in total, for the whole period of the pandemic, England has accrued excess death rate of 169 per 100,000. So that's more people that died in during the pandemic period than would have died if we'd had the average over 2015 to 2019. Now, the ratio for Northwest England to that 169 is we had 200 deaths, excess deaths. And for areas like Blackburn with Darwin and other areas such as Oldham will be in similar, we had 254 excess deaths per 100,000. So at this point in the pandemic, we have a much bigger hit in terms of excess deaths, both COVID and non-COVID. And of course, what the mortality rate showed over the pandemic was that as COVID deaths filled up hospital, or COVID cases filled up hospital beds, ICU wards, and we got more deaths, we also got a parallel rise in non-COVID deaths. And some of that was due to the dynamics I've just described, is that many people who would have been saved if the NHS, if they'd been admitted to the NHS at other times during that high pressure point in the system, simply didn't get life-saving care early enough. Next slide, please. We've looked at our excess mortality up to week 42, which is middle of October. And what we can see is excess mortality, excess deaths, excess mortality rising since week 40, or perhaps week 39. Now, the COVID deaths, we are getting more, certainly in East Lancashire, we are getting more hospital admissions, probably due to the fact that the vaccine is waning in some of our most vulnerable groups. But the deaths are fairly stable. So more admissions, but deaths fairly stable. But the pressure on the system from not enough GPs, staff absences, staff not appointed who are already in the system, and longer waiting lists, a higher percentage of long COVID, of course, which is another consequence of having a higher COVID case rate, means that the system is under such pressure that that factor of delaying urgent and emergency care at the point of need is having an impact already, and we haven't even had the circulating winter virus. Now, of course, the group that are more vulnerable to that are also the group who will have more economic and social vulnerability. So this is a health inequalities issue. The excess winter mortality is going to hit poorer communities harder. Next slide, please. Now, just to give you a broader perspective on some of the risks we carry into that this winter period, ONS data has been severely delayed. For child mortality, which is a relatively new indicator, it was devised about 10 years ago. So, what it is the death rate for children aged 1 to 17 years. So you exclude infant mortality and you exclude adults. So it goes from 1 to 17 years, and it says, you know, how many children died and what was the rate. What we can see from the data that we do have, 2017 to 19, it's a 3-year rolling average, is that of the top 10 worst local authorities in England, the Northwest has 5 in that list. Now, Kensington and Chelsea are in that, of course, because of Glenfell Tower deaths. So I think when we get the next year's data, which will be to 2020, Kensington and Chelsea will not appear there. And, you know, our local authorities will be amongst the highest for child mortality in the country. And of course, we will need to include in that then the pandemic impacts. And we have had significant child deaths during the pandemic. So that is going to be one of our challenges in terms of reducing inequality, in terms of increasing life expectancy. Next slide, please. Now, sorry, next slide, please, as well. one of the things we are going to need to do is consider how much we are resourcing the voluntary community and faith sector with NHS Resources. The NHS is getting a bung from April of 1.25% national insurance tax. Mostly that will come online from then and be distributed. First of all, we need that new resource into the NHS and social care system, but mainly NHS, to be distributed according to need. So the Northwest needs to have some of the factors I've identified here recognised in the resource allocation for that, and it's not clear yet where that is. But the NHS, if we want to avoid continuing excess mortality, not just during these winter months, but over the next 2 years, because of the continuing impact, for instance, with waiting list recovery on the system, we are going to have to find a way of reducing the surge of non-urgent cases into the system. And one of the ways, of course, we can do that is step up our offer to support people in neighbourhoods and communities who may be on waiting lists, may have long COVID, may have exacerbated long-term conditions that the NHS simply is unable to manage optimally. And funding the voluntary faith and community sector to increase the social capital is one way of doing that. Just going back to the evidence from the 2015 mortality spike, one of the pieces of evidence was, it's not well documented, but when people were becoming ill with respiratory disease during January 2015, a lot of them were presenting even to the first point in the system very late. They were already quite ill, quite at risk of death, many older people. One of the reasons why many of them had failed to escalate into the system, even though the system was delayed, was because some of that infrastructure that had contact with vulnerable older people in poorer communities had simply been stripped out. And here is the evidence, for instance, of what was happening to Meals on Wheels during the years before that 2015 mortality spike. Essentially, local authorities were forced by the cuts I showed to strip out funding for Meals on Wheels. That meant many older people, the most vulnerable, the most likely to die, often the poorest, least socially well-connected, did not see people every day as Meals on Wheels were delivered, and often didn't see people from week to week. So when they were ill with a chest infection or a urinary tract infection, which is very common, it wasn't picked up. Their confusion wasn't picked up. They escalated late into the system, were more likely to die. Now, we need to take account of that evidence from there if we want to reduce mortality over the next 2 years and make sure some of that civic community infrastructure is in place. Next slide, please. And this slide is just from Shared Lives Plus. Some of you will have seen it, and I know we all have our own models, but of course, what we need is to create some kind of community-centered support infrastructure at neighbourhood levels in order to be able to identify and act and support those communities at local levels. But the NHS, I think, is going to be the only bit of the public sector with any real new money, and it needs to prioritise this to stop that flow into the system. So one of my recommendations to reduce inequalities is that community funding for voluntary sector bodies on a model something like this is stepped up from April. Next slide, please. Yeah, so I've put it, health inequality, blah, blah, blah. One of the main risks we've got now in the system is that although the NHS is going to get a bit of new cash, most of our systems are already heavily overspent. Lancashire and South Cumbria ICS, for instance, has a structural deficit of 340 million. So already the hospitals were over-treating for genuine reasons because of high disease and illness. I can't believe the Treasury won't say to the Department of Health, yes, we want you to address inequalities, but if your hospitals are overspent because they're treating all these ill people, you've got to consume your own smoke. And if you haven't got enough money left to deal with inequalities, tough, you sort it. And I think there's a very real risk we get into April and the system has no money because we're overwhelmed with demand for treatment. Next slide, please. And in this, of course, the core problem is a structural systemic one in the NHS itself. So the BMA publication, Prevention Before Cure, gives a really good summary of the core problem. Preventable ill health accounts for an estimated 50% of all GP appointments, 64% of outpatient appointments, and 70% of all inpatient bed days. And of course, when motor cars were invented, they replaced carriages with horses at the front, and conceptually, they struggled for at least 25 years to realise a motor car didn't need to look like a horseless carriage. I think with our hospital-centred NHS, with our investment mainly in the treatment of illness, the NHS is still in its horseless carriage phase. And actually we need radical difference in the way we invest the NHS resources for health. And we need to take account of this. This factor is really at the core of why the whole health and care system is not effective at addressing health inequalities and not effective at addressing health improvement. Next slide, please. And of course, we have a population health approach within the NHS, and this is the King's Fund's version. There are other versions. I know Manchester's got doing some great work on this. But balancing out the investment in the health system as opposed to the healthcare system, to invest in interventions and infrastructure more equally across some of these factors would bring improved outcomes and reduced inequalities. Next slide, please. And of course, we have to be really honest with ourselves. The NHS has had health inequalities targets for 30 years, most of my career, and has failed to deliver on them. And there are four main reasons here. Not only has it failed to deliver on them, I have to say it's got worse. The health inequalities have got worse. So there are four reasons here. We've really failed to conceptualize the full causal pathway leading to reduced inequalities. And there I'd give an example. The Northwest has some of the highest rates of type 2 diabetes. Most of its investment with that problem is either better detecting diabetes as it appears, or better treating diabetes. What it's never really invested in is actions that would reduce the prime cause of type 2 diabetes, which is a much stronger approach to controlling food sources and increasing physical activity through infrastructure that would allow us to stop people escalating into type 2 diabetes. We haven't really defined the delivery chain. You know, if we understand what's causing our high rates of type 2 diabetes in the Northwest region, have we defined the delivery chain that would allow us to have the strategic instruments to address them? And if we did that, have we really got a control strategy? What happens if, you know, Rochdale has its 45th application for another pudding shop, but is in the top 3 for type 2 diabetes? Do the local authorities have the power to stop that? Many areas we don't. And lastly, do we have a public health system that's capable of engaging in those wider governance and control issues that are emerging as the reasons why we are failing to address health inequalities? Next slide, please. The Audit Commission did some work on effective delivery systems. Of course, one of the, if we just look at the COP26 discussion, the discussion is kind of in two halves. One is, what are the targets we're all going to sign up to save the world? What are the metrics for those targets? And a lot of the focus on COP26 was on that. But of course, as we got to the end of COP26, the other half of the discussion, the critical half, is what are the delivery systems that would allow us to do this on a global scale? And how are we able to bollock people who don't do it? You know, what's the sanctions? What are the control mechanisms? And of course, that second half is really our problem. We have had targets, we have set metrics, we are cited on many of the problems, but we haven't had effective delivery systems or adequate governance or sanctions for non-delivery of reducing health inequalities. And it's the same challenge, it's a systemic issue, same as COP26. This is the National Audit Office's view on effective delivery systems. Next slide, please. And this is the view from work done by WHO, actually as part of Marmot's European review. We looked at systems characteristics of health inequality delivery systems and said, what needs to be in place if we are able and competent to deliver reductions in health inequalities? We have to acknowledge that the systems we've had in place so far have been ineffective, inefficient, they've failed. If we don't understand why the existing commitments we made to reducing health inequalities have failed, we aren't likely to be able to create that delivery infrastructure that would allow us to be successful in the future. And just, I'm nearly finishing, but just one of the reflections from COP26. One of the things we need is a very different kind of approach to governance. In COP26, you had the state and the state actors sat in rooms negotiating often very complex, detailed agreements about what they would and wouldn't do. They were less effective, I have to say, at discussing the delivery systems and sanctions, but they were trying to discuss what it was they would agree to. But what was clear is that politicians were very nervous, and the inclusion of the lobby groups, the groups that were saying, look, you lot, we need you to just get on and deliver this. We know it's unpopular. We know no one wants to stop driving their big diesel 4x4s, but you've got to do it. And we, the public, we children, you know, young people in the world are demanding this. And COP26 did try to bring in that voice, bring in that pressure as a kind of extra state pressure. And partly it's to give the politicians confidence and headroom to make decisions that are unpopular, decisions that are required and obvious to everybody, but are politically unpopular and difficult to get support for. Now, in the NHS, we have tended to focus in some of our problem solving for health inequalities on supply side solutions. So we've tried to supply the solution, we've tried to intervene in reducing inequalities as providers of services or providers of programs. I think what we've under-conceptualized is the amount to which we need to intervene on demand side solutions. We need to resource and enable communities themselves to be giving grief to us, the system, the state, politicians, about why those inequalities haven't been resolved. And that is a kind of smart governance approach that is very different to the one the NHS as a, you know, the NHS structures are really rather like the Catholic Church in the 16th century, with a magisterium and all the other bits of, you know, centralized architecture. It needs to open up, it needs to be wiser, it needs to be resourcing non-state actors to generate demand for changes in health inequalities in our local communities. Now, some of that is going to be difficult to do culturally, but I think collectively we need to start to learn from what's going on in other sectors. And just as a final comment, I would say, you know, partly the criminal justice system set up police and crime commissioners in order to do something like that. It's a shame we haven't got health commissioners with a kind of role to mobilize the public to demand change from the system and to be that advocate for the public. So one of my recommendations for the Lancashire Marmot review is that we have a health commissioner, not as in, you know, clinical commissioning, but as in that broader working on the demand and supply side of reducing health inequalities. I think that's my last slide. So thank you.
Well, Dominic, thank you so much. There's loads, absolutely loads to think about there, especially the way you triangulated all the data and actually, you know, told an absolutely compelling story about what needs to, well, where we are right now and where we're going. I think that's quite a, strong messaging. And just in the chat, we've had a couple of comments around, you know, how, what does it mean? What does radical actually look like? And how do you bring some of the systemic challenges together? Because it is complex and it is messy. And there's a big call on leaders here. But then when we say strong leadership, does that mean command and control? Are we, you know, exacerbating the issue here? So there's for me, there was a lot there to take on and consider and think about. And I know that people have started jumping in on the chat, which thank you everyone. That was the idea of a health commissioner, brilliant. So yeah, loads to think about, and we will have a chance to talk again just after 12 o'clock when we have a panel discussion. I do now want to move us on and introduce you all to Jane Pilkington, who you know, will talk a little bit about the Greater Manchester system. So Dominic, thank you so much for that. That was amazing. And we will come back to you at 12:15 for more. So Jane is with us here today to share the progress the Greater Manchester system has been making with Sir Michael Marmot. And just to introduce you to Jane, Jane's the Director of Population Health at the Greater Manchester Health and Social Care Partnership. So delighted to you can make it with us today, Jane, and excited to hear what you've got to add to this already. So thank you. Over to you.
Thanks, Cash. Really excited to be here today. And just on Dominic's last point around health commissioners, I think we've got a lot to learn from Wales, who when they introduced legislation around Future Generations Act, they put a commissioner role in there, and I think that's kind of quite an interesting approach. But I think Dominic's really kind of eloquently set out a clear description of the challenges we face in the North West and why. And I guess the rest of the agenda is now focused on how one of our regions, Greater Manchester, has started to is approaching the Build Back Fairer agenda. So if we could move into the slides, I've been asked to talk today about our collaboration with Sir Michael Marmot and his team, and provide a kind of city region, a perspective on the city region's approach for building back fairer. And in essence, what I'm going to cover is I'm going to start with some key context, give you an overview of the collaborative work that we've done together, and then just give you a flavour of the GM system's response. So if you could just move me on to slide 3, that would be great. So it's the next slide. Brilliant. So as I said, I'm going to start by setting some context, because the work that we did with the Marmot team is part of a much longer journey we've been on in relation to devolution, including the devolution of health and social care. And that has really focused us on people and place, and really allowed us to take greater control of our own destiny and focus as a system on not only health improvement, but also the root causes of ill health by joining together and integrating approaches. And I'm kind of often asked what makes Greater Manchester different to other city regions, and how have we managed to position ourselves at the forefront of the debate about devolution. And I guess there are 3 key factors for me to highlight. One is our history of working together, and in the appendices for the presentation, which I'm sure will be circulated, I include a bit of a timeline of the Devo work that we've done. It really does take time to demonstrate the benefits of collaboration, and time to develop effective relationships based on mutual trust and respect. And that's a long-term endeavour. We've also, I think, in our system and our city region, developed a robust evidence base to inform our strategic priorities. And the Build Back Fair report is just one of a number of pivotal reports that provide that independent, kind of constructive analysis and challenge. An earlier report, say in 2009, the Manchester Independent Economic Review was a critical turning point for us, because for what was then AGMA at the time, it made the link between economic growth and health, which we've been continuing to kind of consider and work on since then. And I guess in response to that evidence base, a clear whole system strategy, one that all partners can stand behind, and really understand their role in delivering. Next slide, please. And I guess the devolution of health and social care would be the only system in the country to have kind of full devolution. And that gave us another key opportunity, really, to transform our health and social care. And Dominic set out why that, very articulately set out why that's important on delivering a significant improvement in pop health and reducing health inequalities. And as you can see, our Taking Charge plan had a radical upgrade in population health as the first of its 5 key aims and work programmes. And in recent evaluations of the work that we've done, it points that focus on population health has been seen as a key point of difference from other healthcare systems. Next slide, please. This then led that the development of Taking Charge and the prioritisation of population health then led in 2017 to the launch of GM's first ever population health plan, which set out what are our agreed system priorities and how are we going to use the DEVO opportunities to help everyone here have the best start in life, to live well and to age well. And it was backed by an initial £30 million investment from the Transformation Fund, which was supplemented by additional external funding, such as from Sport England. And I guess it was really a kind of catalyst to action, allowing us to start driving and change at pace, scaling up evidence-based practice and innovation. And it has led to successful outcomes. And again, there's some details in the appendices of the presentation. And we've got evidence that some of these outcomes have been maintained through the pandemic. And I'll just give one example today. So we've managed to get our smoking in pregnancy rates down by nearly a quarter in the last 3 years, and that's the largest drop in England. And also overall, our smoking prevalence has fallen by 2.4%. We've had much higher than national average of smoking quit attempts. I think we've had 52,000 fewer smokers in the first 2 years. And we're just waiting on some national data, but our smoking toolkit study, which we do, shows we are on track to hit 30.5% by next year. So despite the pandemic, we've got that continued downward trend. Next slide, please. And as well, it's important to say that we've continued to iterate our approach over the last 4 years. And we did a significant piece of work with the King's Fund in 2018, 2019, with our GM system leaders to develop what is our population health system approach. And we worked with the King's Fund to develop a GM-based adaptation of the King's Fund model, really. And one of the key recommendations from the year-long piece of work that we did was to ensure that health inequality is a core system goal, and that we really need to embed considerations of health inequality into everything we do, all our policy decision making, every aspect of our city region public services. And it's, system leaders were very keen that we bring in a key authority on this to support us and challenge us to push forward and go further, really. Next slide, please. So in response to that piece of work, really, the population health system, we invited Michael Marmot and his team to work with us. And I think from Michael's perspective, he was keen to work with GM because he could see that we had an inspiring vision for the future. And Marmot really felt they had a key role to play in informing that key vision and making it practical. And I also think, from conversations with Michael, I know he was keen to demonstrate, on the back of the analysis around the 10 years on report and the stalling in life expectancy and the lack of inaction nationally, I think Michael and his team were keen to demonstrate change was both wanted and possible. And despite the widespread cuts, positive action was being taken by cities, by city regions, and people like Greater Manchester were developing whole system approaches to tackling health inequalities. Next slide, please. So I thought it might just be, I just spend a little bit of time setting out some of the important elements of the collaboration that we did in terms of building the evidence base, the refocus the work on the pandemic recovery, how we want to monitor the work and the Build Back Fairer framework and recommendations. So during the 2 years we worked with the team to build, during these 2 years we worked with the team to start building the evidence base and really demonstrate how and why health is getting worse for people living in more deprived districts and regions, but particularly what can be done in that spirit of social justice to take action on the social determinants of health. And together we set out to establish Greater Manchester as the first ever Marmot city region, kind of characterised by a city region system that really puts tackling inequality at its heart, that it places visible, deep-rooted and concurrent action around health, social and the economy, and also that we can hold ourselves to account, that we tackle inequalities, improving health and well-being, but the people and planet stuff is built into all that we do, and that we can see strong values of social justice embedded into our system and organisational culture, processes and systems. Next slide, please. But partway through the work that we were doing, the pandemic hit, but we both clearly saw the need to rescope the work plan to take into account the impact of the pandemic on inequalities and an assessment of the likely ongoing challenges from the pandemic, and to make practical recommendations about how these could be addressed. And I guess whilst the pandemic has clearly exacerbated health inequalities, I think we both felt there were reasons to believe the crisis could be a positive, transformative moment. Certainly, one example is the fact that health and equity was really put at the forefront of our consciousness. And so we really saw that as a key driver for kind of going further. So I thought on the next slide, I'd just remind you of some of the key headline findings from the analysis. There's lots of graphs and analysis in the report, but I just thought I'd kind of just mention two really important things about how the pandemic and its response amplified and exacerbated health inequalities in GM. And obviously a lot of context has already been set by Dominic, but what we found was COVID mortality rates were 25% higher in GM than the national average, and also that life expectancy had dropped by 1.2 years for women and 1.26 for men. And I think at the launch of the Build Back Fair report, I can remember Michael describing this as catastrophic and jaw-dropping to see such drops in life expectancy in 1 year. The why, I think, again, Dominic's kind of highlighted, that's rooted in where GM and other systems were before the pandemic. And it's those inequalities in social and economic conditions before the pandemic that contributed to the high and unequal death toll and reductions in life expectancy. In short, we went into the pandemic in worse shape, and we've come out in even worse shape. Next slide, please. Another key feature of the work we wanted to develop was around developing a set of Marmot beacon indicators that could help us monitor the impact of and recovery from COVID through that equity lens. And the indicators we developed, some of them which are also being used by the overlap with we also fed into work by the WHO as well on indicators. And these indicators underpin our Build Back Fair approach, and they're helping to really build our understanding about health and health inequalities trajectories, and to help inform action and really maintain that focus on social determinants. And a lot of these are already collected in various dashboards in Greater Manchester, but it's their collective intelligence that helps us understand the trajectories. And, picking up on something that Dominic said, I think the other thing that was key to us and to Marmot was transparency and public scrutiny, and the public being able to hold us to account. So these will be progress on these indicators will be published biannually, so we can be judged on our performance. I'm going to talk a little bit later in the next bit of the presentation about the particular approach, the particular different approach we're trying to take to strategic intelligence and data. Moving on to the next slide, all the work culminated in the Build Back Fairer report, which was launched in early 2021. It's a really good, solid document, and there are lots of recommendations in there, and they're built around a Build Back Fairer framework, which we developed with Michael and his team. And it really lays a blueprint, not only for GM, but for other local and national systems about how to build back fairer, focusing in on those interventions that really make a difference. And I won't go through them all. I guess the challenge for Greater Manchester, we did find it challenging for Greater Manchester, but we are determined to do things differently, and we feel this sets a really clear agenda. And we did see this as a moment of change and a positive intervention in our journey. Next slide, please. We also, it's probably also worth pointing out that we also worked with an independent Inequalities Commission, which was chaired by Kate Pickett, and that had a particular focus on the equalities agenda and citizen engagement. And it really focused on the how we do things with people, with stakeholders, how we focus on equality of access experience as well as outcomes. And some of the key findings from that report were, you know, you can only really level up from communities, and any top-down actions and leadership must enable this to happen. The need to be brave about sharing power with those affected by inequalities. By building on what's there, it already recognised the vast amount of good work that's already happening, but we need to go further, deeper and wider. And the importance of continuing to lobby and work with government to lever in power and resources, and also to share that power and resources with national government. So those two reports provided a real call to action for the GM system. So in the next part of the presentation, I'm kind of going on to the so what have we done? So what is our response to the Build Back Fairer report? And obviously this morning it's only possible to give you a flavour of the work that's underway. And also we've got two other presentations which will bring to life the kind of things that are happening in Greater Manchester within localities, within local government. And so I thought I'd just focus this bit of the presentation on some of the key enablers and try to give you a flavour of how we're working differently. So firstly, we've agreed across our system to embed health inequalities into our business as usual, and our overarching system health inequalities priorities and commitments are being put into our Greater Manchester strategy, which is currently being refreshed. That's actually the front of the previous strategy, because we've yet to sign off the new strategy. But it's a real, in this document, in this new strategy, we're really pivoting towards a focus on equalities, wellbeing, sustainability, levelling up the city region and setting minimum targets for all neighbourhoods, a kind of good lives for all agenda, as well as the how's really important to us in this next iteration of our strategy. And it's about, the things we're doing around social value, equality panels, etc. What are those key tools and levers to make sure that we're doing things in the right way. And on the next slide, I'm just giving you a flavour of the kind of commitments that are in the forthcoming GMS strategy, and I'll just pick out a few of those. So there's going to be a set of wellbeing and equality goals, which do incorporate the Marmot Beacon indicators. There's work around Anchor Action Network, building on some early work that we've already done with the Centre for Local Economic Strategies. And, in GM, I think we've got a lot of the building blocks in place, but the work needs coordination and a drive to kind of go further. And that work's being led jointly by the Combined Authority and the partnership with the VCSE sector. Early work's taking place to explore the role of people power across GM. And we're doing some more thinking around that, but we're looking at options for greater use of social democracy and kind of mapping some of the existing participation structures and opportunities, really. There's work around a race equality strategy, which will be led by our GM race panel. And we're particularly keen to increase the number of people from diverse ethnic backgrounds, led by Operation Black Vote. And that work's starting now. We've also set an ambitious target. We'll be setting an ambitious target for every employer in GM to pay the living wage and offer living hours by 2030, and that's building on the Good Employment Charter that we've already produced in GM. We've also got doing some early work around the potential for a community wealth hub to support and grow cooperatives, mutuals, social and economic enterprises, and that will be staffed by people from cooperatives and the community sector who understand that market. And then also, for example, work to explore the potential for a land commission to look at ownership and control of land in Greater Manchester and its impact on inequality, and potential solutions aligned to the work of our GM Planning and Housing Commission. So that just gives you a flavour of the kind of commitments that are going to be in the new report. Moving on, in terms of our ICS development programme, the aim is for our ICS to truly be a population health system with health inequalities at its heart, and it's woven into the fabric of it's a key part of our system design and our key characteristics as highlighted on the and it's part of our key characteristics as highlighted on the next slide. So it's just really what we want to see is that the approach that we're taking around the pop health system and inequalities is just how we do things around here. So we're really trying to fully embed it into our system. Next slide, please. So one of the other key enablers is around getting the governance right, you know, and Dominic was talking about this earlier, and I do think it's incredibly important. One aspect for us, as well as the work that we're trying to do around people power and public scrutiny, is refreshing and strengthening our governance around population health. And historically, our population health board has essentially been a programme board with oversight of plan delivery and a portfolio of programmes, ensuring spend. But we've recognised now that it needs to work very differently, and it needs to have a key role in shaping place, prioritising policy focus led by intelligence, and that ability to hold a mirror up to different parts of the system and kind of using its soft influence and as a lever for our policy ambitions going forward. It will be its ability to influence across the system that it will be a key driver of its success. And we've been having some really great conversations over the last few weeks about how we start to do this. And we're kicking off with a facilitated board development session to help set the direction and how we want to work and how we're going to inform discussions within the wider governance system in early December. It's also been a live discussion within the ICS Transition Board and with some of our key leaders of local government within the CA, and with people like Joe Roney, who's the chair of the Population Health Board and is the Chief Exec of Manchester City Council, to really think about how the system connects through its governance to meet the full range of population health objectives, and and again as well, what's the people voice in that, and what's the transparency and what's the public scrutiny over what we're doing. Next slide, please. So the other element that we want to put a lot more focus on, or are beginning to put a lot more focus on, is strategic intelligence. And our Chief Intelligence Officer, Matt Hennessy, who I'm sure a few of you will know, has come up with this waterfall analogy. He's brilliant at coming up with analogies, and which I'll go through in a minute. But strategic intelligence is often referred, in the past we've kind of talked about population health intelligence, but we think now that it risks being confused with population health management intelligence. So we're trying to make a distinction in terms of how we're looking at it. So just to kind of bring out the waterfall analogy, we see business intelligence about understanding, say, the size of the pool at the bottom and what flows into it, and the water falls and flows this side of the bridge. If you can just see the bridge on the picture. Population health management is therefore about understanding and shaping what happens this side of the bridge and influencing and diverting the water flows. Pop health programme intelligence includes the prevention activities before the bridge, the water kind of management schemes upstream, if you will, the reservoirs, the floodplain management, etc. Whereas the strategic intelligence itself concerns itself with that entire water cycle, everything that happens from mountain to sea, including the clouds, air temperature, evaporation, topography, etc. And what we feel is that the system requirement for strategic intelligence is really expected to grow significantly from what it was in 21-22. And that is because a light has been shone on our long-term health outcomes and inequalities. And I think today our capacity has tended to sit behind core business intelligence and delivered in lots of multiple places across GM, and usually as a kind of offshoot of programme activity. And what we understand now is that we really need to build that central capacity in order to drive the agenda. And some of the things we've been talking about, some of the requirements of that function, we're just beginning to describe now. But I guess it's an increased focus on doing the right things, not just doing things right. We're having a renewed focus on the value of the qualitative data and working with our BCSE partners to collect that, and also understanding the kind of nuanced interdependency of our measures, and we're working with some academic partners to develop this. And on the next slide, I just wanted to kind of go back to the example of the Marmot beacon indicators and how we're trying to approach this a little bit differently. And before I kind of explain that, the context for this is the work that we've done during the pandemic and our learning through that. So at the kickoff of the pandemic, the problem was no data. And then data landed, but it was going in its kind of raw form into the top decision-making fora. And what happened was senior leaders were interpreting data on the fly, and it was taking up the entire meeting. And even presenting visuals in pretty pictures didn't help without kind of clear narrative. So what we established through our contained cell with Director of Public Health Leadership was a COVID assessment processing framework, which provided the expert analysis, which enabled us to take the kind of interpretation bit out of the senior meetings so that they had the interpreted truth, which allowed them to focus on the decision making. And we've now translated that successful approach into our Build Back Fairer assessment process for the Marmot beacon indicator process. And I've tried to describe that slide, the process in the slide. So we'll have a data development group to collect the data, curate and analyse it. And then we'll have a qualitative and expert insight input from an expert system group. And that will then provide an assessment of the current Build Back Fairer situation and trajectory, which will then go into our governance systems to inform and enable decision making. So it's really trying to go beyond a traditional dashboard approach into much more of an expert narrative. So it's strategic intelligence driving the system. Moving on, the other element that one of the other elements I wanted to flag was building our capability, investing in people and leadership. Our work with the King's Fund and with Marmot has pointed us to the need to build system capacity and leadership for health inequalities. I know in Marmot's 10 years on report, you know, he talked about a social determinant workforce, for example. And we're currently in the process of working up proposals for our system offer and aligning investment to it starting this year. And so that's around things like creating universal access to online resources and training, putting in a comprehensive programme of health equity fellowships. We've already got some for violence reduction in our violence reduction unit, but we want to really supercharge this. West Yorkshire are doing some great things. You know, I think there's quite a lot of good work going on in this area. Building our networks of practice and making sure that our executive leaders have the right support, prioritising our chief finance officers and political leads as well, I think will be important. In relation to the next bit, I just wanted to go on to talk about investment. It's absolutely key that we start to invest differently. And again, that was quite a big theme and challenge around Dominic's presentation. And yes, we have invested in Greater Manchester, but basically the approach has been, you know, discrete short-term pots of funding for, by and large, for population health. But the real prize is not the continuation of a £30 million transformation fund, but it's how we reorientate the total spend in the borough towards prevention and health creation areas of spend. And I agree with Dominic about the investment in the VCSE sector. I've already had some small victories in getting some of the legacy population health programmes mainstream funded, but we need to do so much more. And if on the next slide, I've just illustrated here the fact that preventative care remains a really minor benefactor of public funding. If you look at health spending in the UK in 2018, it's only 5% of public funding. And in the 30 years that I've worked in the NHS, it's not really changed, and we've really got to shift the dial. And I know this we're all fairly familiar to you, and we're preaching to the converted, but it is, how are we going to really make a difference on this? On the next slide, prior to the pandemic, we started to explore the various opportunities and levers around different approaches to investment. We did some quite good work with Deloitte around NHS payment reform, and we've made some significant strides as part of taking charge to have pooled budgets at a local level across health and local government, which has enabled a greater focus on the drivers of health, which is the key building, and it's a key building block for our ICS going forward, those pooled budgets. I won't go through everything on the list, but that's in the diagram, but there are opportunities. But what we want to do now is revisit the work in light of the current context and set out a work plan. I think this is really hard stuff, but I think unless we get this right and start to invest differently, we won't make the headway we need in terms of inequalities. And lastly, I just wanted to talk about another key enabler of the work is that we've done and we continue to cement is the unification of our public health leadership at city region level, so that our public health leaders work together to build consensus and speak with one voice. And so that's our kind of expert public health resource I'm talking about across locality DPHs, which are our core and our heart, the resource we've got in the partnership, as well as PHE as it was. And that has evolved over time and was delivered to great effect during the pandemic. And it's now really embedded as a way of working. And the next phase for us is how we develop a shared support infrastructure, a kind of single policy support advisory function, which creates that kind of single system-wide resource for our integrated directors of public health and population health network. And we also need to look at how we align to the new regional and national public health structures as well. So that's really the end of the presentation, I guess. Just in terms of concluding comments, we are on a journey. We are by no means cracked it. And I just hope what I've provided today is food for thought. But the next two presentations, we're really lucky today to have presentations from Paul Dennett, Mayor of Salford, and Keith Cunliffe, Deputy Leader from Wigan Borough Council, key political leaders in our system who have a real passion for population health and health inequalities, to give you that perspective from a kind of local government perspective as well. So I will pause there and hand back to you, Cash.
And Jane, I love the introduction to the next two speakers as well. Thank you for that. I couldn't have done it better, to be honest. So yeah, that's again a lot to take in there. And I've been scribbling away frantically here with some sort of the notes and actually a couple of themes and a few links to Dominic's piece earlier on, and actually later on we'll have Sir Michael talking to us. I think that strategic intelligence piece is really quite important, because often the work we do with those leaders, they don't have much time to make those decisions, and actually it's really important that you do that interpretive piece before they can be in that space. And actually it's about how we can enable and empower good decisions to take place. I love the piece around power sharing, voice. So there's loads of connections between what you were sharing and what Dominic was sharing. So Dominic was talking about his strategic intelligence. So there's something about how do leaders engage others with the intelligence, and the waterfall analogy was brilliant. And you do it through stories and you do it through analogies and examples, so that you can enable a much wider group of people to engage and involve in it. So yeah, all of that landed really well. Also, Louise has put some themes in the chat. So again, for colleagues who want to just take a moment to reflect there, I think it's important that we we, ask you, where are you now after you've heard all of that? So maybe take a minute to think about what's landing for you. Okay, so Jane, you've done a great job already. I'm not going to repeat anything you've said, other than in the introduction piece that I have here for Paul, he described himself as a sensible socialist and much more of an interventionalist than others locally. So I like this already. So without further ado, I'm going to hand you over to Paul to share the Salford story, and how has Salford tackled inequalities in a local way. So Paul, over to you.
Okay, thank you very much, Cash, and good morning to everyone. Absolutely delighted to be here today. Talking about building back fairer and levelling up. And in many respects, when I hear those terms, they're not new really for the city of Salford. We've been thinking about delivering on a better and fairer agenda for certainly the last 6 years since I've been honoured with being elected as the mayor of this city. But also, we've been, I guess, uneasy with the dominant economic model of this country for some time. And, as a consequence of that, intervention and the relationship between the state, the market, the community, voluntary, social enterprise sector, for me, is very much where it's at. And anyone who's familiar with the city of Salford will know recently we've celebrated 10 years of the BBC coming to this city. And for me, what's happened in terms of transforming one of the world's biggest inland docks into what we now know as a broadcasting media digital tech hub, that is a fantastic example of building back fairer and levelling up the country. And as I say, that started many, many years ago. So we've been on a journey. But before I talk a little bit about what we've been doing over the past 6 years, I do think it's really important to contextualise the conversations we're having today and why, in many respects, we're at this point in time where we're even talking about building back fairer and levelling up the country. So we know post-industrialisation and the transition to a service-based economy, the dominance of financial services in the City of London, inevitably created huge challenges for Salford, for Greater Manchester, and for the North economically, which then translates into health inequalities, implications for our communities, and also implications for how we collaborate and where the resources are to enable some of that. We saw in the 1980s the emergence of privatisation, and then later this whole notion of new public management. And we saw things creeping into the kind of lexicon around private sector efficiency, compulsory competitive tendering started in 1992, private finance initiatives, public-private partnerships, which all pointed to the dominance of the market, often over the affairs of the state. And that, for me, led to what I would refer to as a hollowing out of the public sector, especially local government. And obviously 11 years of austerity and local government cuts has only, in my opinion, exacerbated what was started back in the 1980s with privatisation, continued under new public management, compulsory competitive tendering. And we also know when it comes to the last 11 years in terms of austerity and cuts, local government has bore the brunt of that agenda. My local authority has seen over 220 million cut from its revenue budget in terms of not funding through the revenue support grant or unfunded budget pressures that we as a local council have literally had to deal with on a daily basis. So, when you contextualize it in that way, you realize that to truly level up this country and to truly resource adequately the public services for the future, we've got a long way to go. And anyone who's familiar with the recent budget and spending review will have seen the headline figure, 1.6 billion going into local government, but we're still really unsure about what that actually means for local government moving forward. We think probably the national insurance employer contributions will be part of that figure. There's some ring fence funding around government priorities around cyber security, supporting families funding. So we really, you know, for the medium to long term in terms of financial planning at the moment in local government are genuinely struggling, and we won't get clarity until we get the local government finance settlement in December of this year. But in addition to austerity and obviously the lack of clarity at the moment off the back of the spending review, what we've also seen, which is really important, I think, for this agenda in terms of health inequalities and poverty and how we work collegiately to tackle some of that, we've seen the dominance of the use of what I would refer to as regressive forms of taxation to actually finance public services. So we've already heard about the additional money going into the NHS in terms of increased national insurance contributions. And in local government, we've seen huge hikes in council tax, the introduction of a new adult social care precept to create, you know, financial sticking plasters, if we're all honest with each other, to tackle the social care crisis, and obviously increases in VAT. These are flat taxes, and you know, I think we all need to acknowledge that they disproportionately impact the poorest in society when we look at the impact on individual and household income. So there is an urgent need, I think, you know, to have, you know, more progressive conversations about progressive taxation ultimately, if we are going to tackle some of the real structural economic issues and taxation issues that are having profound implications for our people here in Salford, but also in Greater Manchester and across the country. And if we're serious about tackling the social care crisis, we need to get serious about progressive taxation. And just to add further clarity to some of the uncertainty ahead of local government, we're still waiting for the fair funding review. We know there's going to be a business rates reset. We're waiting for government's clarity on some of that. Year on year, we don't know what's going to happen with new homes bonus, and also there seems to be a bit of uncertainty around the 100% business rates retention pilot here in Greater Manchester. So all of this really points to a challenging future when it comes to planning and resourcing, workforce planning within Greater Manchester and within local government more generally. I think when we turn to the impact of the pandemic, we know COVID-19 certainly hasn't been the great leveller that government initially talked about. We know Black, Asian, minority ethnic communities have been disproportionately impacted, both in terms of the impact of COVID, but also we know many people from those communities have been very much the front line during the COVID-19 pandemic. And also we know the poorest in terms of, you know, the socioeconomic impact of COVID have also been disproportionately impacted. So moving on to Salford now, if we could go back a slide, if that's okay. So we've seen a decade of growth in the city of Salford. You know, 24,000 extra residents. It's a growth of 11% over the last 10 years. 2.6 billion of private sector investment. 14,000 additional jobs growth, representing 11%. 1 billion GVA increase, 23.1% increase there, 40,000 new homes, 40,000 new jobs. You know, these are fantastic statistics. And obviously we've got a clear vision for the future in terms of the realization of an inland trimodal port, you know, contributing to our net zero carbon targets and carbon neutrality here in Greater Manchester by 2038. Media City UK is set to double in size over the next 10 years. Salford's recently landed the 5th National Royal Horticultural Society Garden, creating a huge visitor attraction asset and also a myriad of opportunities, jobs, apprenticeships for people here in the city. And we've got a clear vision for the Crescent Master Plan, jointly working with the University of Salford. So we've got a vision for the future. We know where we're going. And obviously, you know, looking to the future pre-COVID, the current pipeline of development was forecasting a 3.9 billion of private sector investments by 2040. So a bright future. And one of the things we know about the Greater Manchester economy is it is slightly more resilient than other city regions and economies around the country outside of London. So despite having a clear vision, you know, change and uncertainty seems to be the norm of the day. And when we talk about Media City Phase 2, we're trying to understand those new industries of the future. People often talk about Industry 4.0, augmented reality, 5G, Internet of Things, big data and analytics, cybersecurity. We're very much operating in that space to, move beyond seeing Media City as just something for media and broadcasting and harnessing those new industries of the future. We also work collaboratively across our hospital, university, and with Media City UK. We talk about the innovation triangle. Government has talked a lot recently in the run-up to the spending review about the absolute importance of R&D and innovation to drive forward UK PLC and our economic strategy. Also on RHS Bridgewater, for me, it's a kind of best kept secret, but 60% of the city of Salford is actually green. And for me, the success of RHS Bridgewater isn't necessarily the garden itself, but it's what that does in terms of the catalytic impact that that actually represents for the city in tackling climate change, greening and colouring the city, linking it with what we're trying to do on active transport, walking and cycling, and all of that activity that very much sits under that banner. So moving on to the next slide. So despite this fantastic achievement over the last 10 years and obviously looking to the future, Salford is still a city of contrasts. We are the 18th most deprived local authority in the country, according to the government's own index of multiple deprivation. You can see from the slide there, 34.4% live in highly deprived areas of the city of Salford. 17,955 children live in poverty, and that's 34.8% when compared with the England average of 31%, so higher than average. 7.3% unemployment rate, that's looking at July 2021. Obviously, COVID will have had an impact there. 3 years life expectancy gap for males when compared with the rest of England. 2 years life expectancy gap for females, again, when compared with the rest of England. And 5.2% of young people are not in education, employment and training. So clearly what that tells me is despite the success, the economic success of Salford over the last 10, 20 years, actually there's something quite profound here about our economic model that we really need to reflect on and change. So we've been doing a lot of work thinking about this. So if we can move to the next slide. Great. So we talk about the Salford Way. So this is the work we've been doing over the last 6 years. And the Salford Way, or sensible socialism, I call it, is all about the relationship between people at the end of the day. When we talk about systems and organizations, when we distill it down, it's all actually about people. The world for me is socially constructed. So we're on with trying to create a better and fairer Salford for all. And after I was elected 6 years ago now, we distilled the mayoral manifesto into what we call the Great Eight, and you can see them there on the slide. Tackling poverty and inequality has very been at the heart of what we've been trying to do over the last 6 years. It underpins everything. Education and skills, there are challenges in Salford. Our primary school estate performs very well when we look at Ofsted ratings, but something happens in our secondary school estate in terms of academic attainment. So we're on with looking at that with a view to try and improve academic attainment in the city. Also, we know we have an issue with young people going on to higher education. It's not where it needs to be. And recently, the council has kind of put its money where its mouth is, putting 1.5 million into a skills and works programme for the city, working with our schools, our colleges, our university, our employment providers to really drive an agenda here of tackling those issues within the labour market. And some of this isn't about education and skills. Some of this is just about developing confidence, time management, some of the softer side of actually getting people active in the labour market. Health and social care, you'll all be familiar. Salford's been at the vanguard of integrated systems, working with our CCG, our hospital, our community and voluntary sector. And obviously that partnership, that collaboration continues in light of the most recent NHS reforms and the emergence of ICSs and how all of that plays into all of that. Inevitably, in the short term, and it's already been referenced in previous presentations, there will be challenges around hospital waiting lists and obviously tackling the crisis in social care. And I think, given some of the scarcity of the resources, given the scale of the challenge, we are going to have to prioritise in that space moving forward. Economic development remains a critical feature of what we're trying to do here in Salford, but what we want to do is create an economy that works for all, which speaks to the Salford way. It speaks to my agenda of interventionism. Housing, affordable housing and homelessness. I mean, I could talk the entirety of this speech about what we're doing in that space, but we've created a wholly owned development company outside of the housing revenue account, and we are building council houses again in the city of Salford, and we're trying to build them at higher standards. So what we talk about is fabric first or net zero carbon homes. We're doing that to put pressure on the market to actually take seriously some of the challenges around tackling the climate emergency when it comes to the homes of the future. Transportation and digital connectivity continues to be a priority, and I think all of us will be watching eagerly today about the announcements around Northern Powerhouse Rail and HS2, and it doesn't look great news from what I've been reading in the press for the North, but inevitably in that space we need to continue to work within the combined authority and also transport for the North and national level to ensure we get the investment that the North and Greater Manchester and Salford rightly deserves. We've increased our focus in all of the Great 8 on tackling the climate emergency, but also the skills and works agenda. Those seem to be, off the last 5 years of being the mayor, areas where I feel we can really accelerate some of the work we're doing. But under all of this is genuine engagement and involvement. We talk about co-production, we talk about the importance of lived experience, and I'm really pleased to say, working with my mayoral team and senior officers of the council, we have taken that agenda really seriously. We've had a Poverty Truth Commission in the city of Salford. We're on with our second one of those, and that is genuinely empowering our residents and communities to tell us what matters to them. And off the back of that work, they help shape policy, strategy, processes, and decision-making here in the City Council. Ultimately, it's putting people at the heart of what we do as an organisation, and it is about genuinely doing things differently. So all of this for me talks to what I would refer to as new municipalism or neo-Keynesianism. It's about the role that the state, i.e. local government in this case, and city regional government plays in terms of shaping our communities, tackling inequalities, and driving forward with an ambitious visionary agenda. So if we can move to the next slide, please. So on tackling inequalities, I think it's fair to say, and it's already been said in previous presentations, we all acknowledge the complexity of the issue. And I think there was a comment earlier that, the NHS has been talking about this agenda for 30 years and actually hasn't made much progress. And I think for me, one of the reasons maybe we haven't made much progress is because we've not adequately thought systemically about how we tackle poverty and inequalities, because everything is connected, everything is related. I said earlier about the world being socially constructed. Look at the labour market, huge challenges in terms of low pay, insecure employment, 0-hour contracts, part-time employment. How do we change all of that? Well, we do that through things like employment standards. Yes, we can do it through changes in national legislation, but we do it through intelligent commissioning and procurement. We do it through those conversations around social value, social impact. Look at the housing market. At the moment, a lot of the homes built are not affordable. Wages have fairly flatlined, but property prices have grown exponentially, and generations have been cut out of the whole notion of home ownership if it isn't for bank of mum and dad. So there are structural issues here, and I think we need to consider our agency in that space and our partnerships in that space to tackle some of these huge challenges. Again, on education, skills and work, huge challenges there to make sure the system talks to each other. And something I've always been really passionate about is education, skills and work cannot and must not sit in isolation from what we're trying to do economically, and thinking about the businesses of the future, how industry is changing, and ensuring that curriculums speak to the economic requirements and the skills requirements of the future as we transition as a national and global economy, because many of the jobs of the future are not actually known to us today. So ensuring that there is that industrial collaboration at the heart of the education skills work within the city of Salford, again, has been very much at the heart of what we're doing. I mean, I won't go through all of these areas, but I think what I'm trying to illustrate in this slide is that if we're serious about tackling inequalities, we've got to get serious about systems thinking, and we've got to get serious about understanding the interrelationships between these spheres of activity. And obviously for Salford, we sit within a Greater Manchester context, we sit within a devolved context. So our relationship with Greater Manchester in all of this is absolutely critical, be that through the industrial strategy, the 5-year environmental plan, the plan for homes, jobs and the environment, now called Places for Everyone, which is about spatially planning, up until 2038, a considerable time in the future. So that informs the action plan, that informs what we do in the agency of the system. All of this really matters. And for me, I think, we could talk about one of these areas for a long period of time, but what I'm trying to illustrate here is, it isn't just about treatment. It isn't just about, the prescriptive side of health and social care. It's also about the preventative side. And if we're serious about stemming the flow, we need to get serious about how we transition to a better, fairer and greener city region that benefits all and all feel part of and involved in. We can move to the next slide, please. So when we talk about inclusive economy and the Salford Way and our recently launched economic strategy, I think what I would highlight is that behind all of that activity is strong partnerships. I don't see it as a strategy for the city of Salford, so the city council. It's a strategy for the city of Salford. So the council, the university, the CCG, the Foundation Trust, our community, voluntary and social enterprise sector, all are embedded in the creation of this strategy. And obviously that's supported by academics and think tanks like the Centre for Local Economic Study to ensure that we're taking an evidence-based approach to what we're trying to create here in the city of Salford. But fundamentally under the Salford Way are what we refer to as kind of 5 action plan points. So one of them is about building local community wealth building. So we want to keep the Salford pound in Salford. We want to support local businesses in the city. We want to speak to the industries of the future, but we want to do that in a way where the people of the city benefit from that, which does talk to the council being more interventionist on capital. People will be familiar probably with the Preston model, and in a sense for Salford, we want to have our cake and eat it. Yes, we want the economic growth, we want the investment, but we also want to lever that and manipulate that so the people of the city are the beneficiaries, and we don't just continue down this road of an extractive form of economic growth at any cost. Neoliberalism has fundamentally failed us. We talk about the benefits of neoliberalism being that all boats will rise. Well, that hasn't happened. Poverty and inequality has worsened under that economic model. So we have to think of new ways of engaging with economic growth and the market. The growth of the social economy sits very much at the heart of what we're trying to do. So cooperatives, social enterprises, whole range of different things we're doing in that space. I mean, some good examples of that is the work we're doing with the Broughton Trust, where we're using our land holdings and our borrowing powers to create community housing, which will then create a revenue stream for the Broughton Trust to support what is a fantastic community voluntary organisation in the city of Salford, doing great things with young people furthest away from the labour market and young people who are not in education, employment and training, but using housing as a vehicle to ensure that there is financial stability for that organisation is something we're really keen to do, in addition to challenging the dominance of the market in terms of being the primary driver for obviously how homes are built. Transition to a zero carbon economy, obviously lots of work in that space. We've got a target now in Greater Manchester of 2038 and 2028 for net zero carbon homes within Greater Manchester. Lots of work going on in Salford, creating solar farms in Little Hulton, building hydroelectric facilities on the River Irwell in Charlestown, 126 million we've spent on green infrastructure, walking and cycling over the last 10 years. And that has been an absolute godsend during the last 18 months with COVID-19, as people have enjoyed the green spaces and in many respects have discovered their city, and obviously continuing on that journey to invest in our green spaces, encouraging active travel is going to continue to be a priority for us. Promoting and enhancing public services. I've established an insourcing commission. We've already brought services back in-house into local government, putting people onto green book terms and conditions of employment, tackling some of the ills of what was referred to, in my opinion, as new public management, the contracting out and commissioning of services. And we need to continue on that journey, especially looking at social care moving forward. Obviously, all of this is inextricably linked with what happens with local government finances moving forward. And then strengthening civic participation and local democracy. We've been playing with governance now for some time in local government. Certainly in the city of Salford, the Integrated Care Organisation is a great example of that. The Poverty Truth Commission is another good example of that. But we need to not become complacent, because for me, it is all about engagement with our residents, our communities, our private sector, our community, voluntary and social enterprise sector, and other public sector institutions, and our university as well. And it's through those playing with governance and civic participation and local democracy, I think we can deliver real innovation and meaningful change within our communities in our city. And obviously all of this translates into clear ideas and practical action, because I'm not a fan of strategies for the sake of them, and I'm not a fan of talking shops. It is about getting things done, and that's much what's been driving us, I would argue, in Salford over the last 6 years. We can move to the next slide, please. So on social value, we have a strong VCSE sector, you'll see, and we have a vocal model for voice and influence. The VCSE sector permeates all activities within the city and are invited to all strategic meetings. I meet all the health and social care leaders, and at the table there at the top level is the chair of the voluntary and community organisation in the city of Salford, Alison Page, driving the absolute importance of the VCSE sector within everything we do. We've got a social value alliance as well, which is about holding everyone's feet to the fire on a whole range of different metrics to deliver on our 10% better campaign, looking at the triple bottom line, so looking at social outcomes, looking at environmental outcomes, and improving our economy, but doing it in a way that genuinely benefits the people of Salford. We established an employment standards charter back in 2013. That was under the previous mayor prior to my tenure, and that has been very much the precursor for what we now see at a Greater Manchester level in terms of the Good Employment Charter. So, more work needs to happen in that space. We've overachieved on our target to encourage employers in the city to become real living wage employers, accredited by the Living Wage Foundation, which is fantastic. And obviously this week is Living Wage Week, so a really timely point to talk about that. Salford as well was the first council within Greater Manchester to become an accredited living wage employer. And we were also the first city to be recognised for our endeavours outside of the City Council to encourage the city to also take this agenda seriously. Social Enterprise City, again, is just a recognition of all the work we're doing in that space to encourage social enterprises, to ensure they're embedded in our procurement activity, and to actively champion their services throughout the city and encouraging people to buy social. And then obviously tackling some of the challenges around digital exclusion. We've been working long and hard with the Good Things Foundation. We were recently recognised by DL100 for the great work we did during the pandemic in establishing the Spirit of Salford platform, which was a digital telephony platform, supporting people with social isolation, picking up their medicine from the chemist, shopping, a whole host of different things. And, it was great to see that recognised. Again, that was very much a partnership with the private, community and voluntary sector, as well as public sector bodies, our university, and obviously the City Council that facilitated that. And I think I'll end on this last slide, which talks about what we've been doing in terms of tackling poverty. If we can move to the next slide, please. So I did say at the start, tackling inequalities and poverty has been very much one of the things that has characterised, I would say, the last 5-6 years of me being the mayor. And what better way to highlight some of that than to highlight with all of you some of the achievements in the city. We've boosted pay for over 3,000 care workers. We've increased the number of accredited living wage employers to 55. I think we've actually overachieved that target now, way over that. We've reduced the number of people earning less than the real living wage from 16.5% to 14.5%, the best rate in Greater Manchester. We actually have a task force whose sole job is to encourage people to become accredited with the Living Wage Foundation and to ensure all employees are paid at least the real living wage. We've reduced rough sleeping by 80%. We've reformed the way we collect council tax and obviously use bailiffs in that space. We've built more social homes, launched Derive, helped around 14,842 people claim an extra 20 million in missing social security entitlements. One of the first things I did when I came to office was actually protect the welfare rights and debt advice service here in the City Council, working with the CAB. Why? Because I saw the critical importance of that in a city which has huge challenges with poverty and inequality. And although it's a non-statutory service, so we don't get a penny from government to deliver that service, you can see for yourself, bringing £20 million worth of missed social security entitlements into the city will have a phenomenal impact on people's lives and people's health and well-being. More people now are using food clubs than food banks in the city. We are pushing food clubs because we see the importance of the clubs. It's like going shopping normally. There's more dignity in that approach, in my opinion, and we're wanting to build that as a network throughout the city. And we've improved digital skills of up to 8,000 of our most disadvantaged residents. We understand the absolute importance of digital skills, both in terms of applying for jobs, being able to interact with loved ones around the country and around the world, and also just getting on in life. Digital skills underpin labour mobility within the labour market. So that has been an absolute critical priority for us. But I think all of this points to how we work in collaboration and partnership, and how we take leadership and the agency of local government within a devolved arrangement in Greater Manchester really seriously. I mean, there's no room for complacency in this space. We need to learn off the back of what we've been doing over the last 6 years, and we need to accelerate this further. And government nationally needs to work with us on this agenda, because if we are to deliver building back fairer, and if we are to deliver on levelling up, we really do need to place tackling poverty and inequality at the heart of what we do and why we do it. There's lots of things I think we need to do in terms of lobbying and influencing nationally, and I talked about some of those in the opening gambit, in terms of the challenges with local government financing, the history of why we are where we are, and also looking to the future in terms of what all of this may or may not mean for devolution. And obviously we anticipate the government's levelling up white paper in the not too distant future. But hopefully that gives you some insight into what we've been doing in the city of Salford, and happy to take any questions or comments. Thank you very much.
Wow, Paul, thanks so much. There was so much in there. Yeah, and there were a couple of themes that I've picked out just listening to you. I think the last bit you summarized, which was that how you get things done, partnerships, relationships, engagement, that strategic intelligence piece Jane was sharing earlier on. You've put that right at the front line. I love the banner, by the way, the Poverty Truth banner. Really powerful, really powerful. So that shows me as a complete layman your approach, and actually, you get things done. And the other point, just to make before I bring Keith in, I know Keith, you're on now talking about the Wigan approach, but there is something there about the paradigms that these things have been built on. The paradigm for local government. So I think you are, as an organisation, both award-winning, but also really being like almost a vanguard council. So you're shaping what local government could look like in the future. And the way you described it was really evident to me around what you see your role as being, almost a platform for all these other organizations to come together and make sense. And that there's something there that we can think about. And the other paradigm shift is the neoliberalism, the thing that's in the chat box that I know there's been a question answered in the chat box, but actually, you know, these foundations have shifted significantly. We've got the data to show it, but what you're doing at the moment and continuing to do is doing things, trying things out, being experimental, getting things done. I'm sure you get things wrong, but that's okay, you learn. So it's really quite inspiring to hear some of the action that you're taking, and you're not waiting, you're just doing it. So it's, yeah, really, really good. I'm just going to bring Keith on, just Paul, because we've got a panel discussion hopefully shortly, and we'll be able to ask you some specific questions about how you've done it, if that's okay. So Keith Cunliffe, somebody we know really well at North West Employers, Deputy Leader of Wigan Borough Council, responsible for all things relating to improving health and wellbeing for the people of Wigan. So I want to present Keith to you. Keith is going to share the local response about how Wigan are, you know, building community wealth building at the heart of their recovery. So Keith, great to have you here, and fantastic session for you to be part of. So I'll hand it over to you. Thank you.
Right, thanks very much, Cash. It was interesting for me listening to the tail end of Paul Dennett's presentation, and I think what it tends to highlight to me is that within Greater Manchester, the local authorities, because very much the Wigan approach is following the same direction as Salford, but each doing it in our own way. But the general principles that underline it, I think, are shared, and for me that expresses the crucial role that local government can play in building back fairer. So if we move on to the next slide, please. So the interesting thing for me is, and I've had the health and social care portfolio for quite a number of years, and my background is as a mental health nurse in the NHS for 40 years. But what's significant about Sir Michael Marmot's reports, both in 2010 and more recently across GM, is that actually health is determined by much more than actual healthcare, social care, physical care. The wider determinants of health, primarily socioeconomic impact that it has on people. And so in thinking about community wealth building, actually, if you're improving the socioeconomic conditions of our residents, of our communities, of our citizens, then we will have an impact on community health building. So if we move on to the next slide, please. So I think it's important that each local authority in each area develops its own move towards what we're trying to achieve. And so I started with the Wigan Deal, which is well known and which has been highlighted by the King's Fund. And initially that was an informal contract between the citizen and the council. And so what it's done, we've had a long journey since then, but it was nurturing that relationship about harnessing the powers that exist in communities to find better solutions. And of course, we were addressing austerity at the time, and it was around meeting the budget challenges and developing something different, a different relationship, a different culture, a different approach about connecting people with community, about place-based working, about integrated teams in a place, having knowledge of your community. And so developing that different culture and that different relationship between the local authority and its residents. So if we move on to the next slide, please. The principles around the deal really were sort of 4 or 5 main principles behind it. And what we were seeking to do was have different conversations with people, because it was about adopting an asset-based approach. It was about not doing things to people, but working with them and co-producing with them individually, connecting them to and building community capacity, and more important, knowing your community. I think if you go back, you know, to those halcyon days that everybody seems to remember as the golden years that never really existed, but, you know, where the GP had the local health visitor and the social worker, and they knew the area and lived in the community, and that sort of relationship. And a lot of people felt that things had moved away from that into a more bureaucratic assessment, structured way. And so having that different conversation with people, what's a good day look like? What do you enjoy doing? What did you enjoy doing, but you can't do now for some other reason? But connecting that and building on the community capacity and what already existed within the community. I think very early days, I think there's an LGA document where I was quoted as saying, actually with less finance, less financial resource, and therefore less people resource, we're actually got an untapped resource that we're not tapping into, and that's the 325,000 people that live in this borough. And so developing that strong relationship, and I think what Paul was saying earlier is really important, is that over the years of the deal, what it's enabled us to do is develop really strong public sector relationships and relationships across the voluntary and community sector and with business. The deal, if you like, has given us a beacon for us all to latch onto and to share and develop. And of course, the behaviours applied to the deal are about encouraging staff and people generally within the public sector to be positive, to look positively at different ways of working, to be courageous, to give people freedom and flexibility to be innovative, and to be accountable, and to be kind and compassionate. And one of the most important things that helped us along that journey was the co-location of teams and partners in a place. And for me, that was more about integration. I think there's a milk test to determine whether you're co-locating teams and partners or whether you're integrated. If you go in and to any place and open the fridge, and there are several bottles of milk with community nursing staff, social workers, physiotherapy and all those, if there's about 6 milk bottles, all individually labelled, then the team is co-located. If there's 1 bottle of milk in the fridge, they're integrated. And so that development of that integrated team working in a place had a significant effect. So those workforce cultures around the BWIG behaviours were really important. And what we started to see is that I can't say that it's completely because of this, but we've had we've doubled the spending on prevention and early intervention. Our reablement team was 4 staff in 2008. It was 22 staff in 2011, and it's now 82 staff and increasing, because it's really important in terms of reabling people, enabling them to maintain their independence as long as possible. And so that co-location of teams, but working in an integrated way, has had a really important impact. And what we've seen over the years in Wigan is that we're actually bucking the national trend. I mean, we do have poorer health statistics than the national average, but actually, when the national average of healthy life expectancy is coming down, in Wigan, it's actually increasing. We're improving life expectancy. We're increasing healthy life expectancy. And I mean, my view would be that's part of the approach that we've taken in connecting people and developing this culture of working together. So if we move on to the next slide, please. Prior to the pandemic, we were working with CLES around community wealth building or developing community wealth building. Because one of the things about the deal was there were elements of the deal that had community wealth building in. And so some of the improvements that we've seen and some of the reductions in demand that have occurred within our services have come about because there were community wealth building payoffs that were unintended. We hadn't done it with the intention of community wealth building, but the impact of it. So developing an ethical home care framework, working towards dealing with some of our housing issues. And if I look at the situation in Wigan with regards to housing, I think over the last 3 to 4 years, the number of people on our housing waiting list has increased by 121%. And certainly over the last 18 months, 2 years, it's increased significantly. So we've gone from 6,000 to 7,000 up to even last year, 10,000, and this year it's 12,500 people. So actually developing ethical lettings agency, empty homes initiative, actually quite an ambitious programme around direct provision of social housing and providing supported housing and housing with extra care has been significant for those more disadvantaged people in the community. So we'd recognise that community wealth building is community health building, and was something was moving on. And then 2020, we get hit with the pandemic. And actually the implications of that mean that not only do we have to develop community wealth building to improve the health of the population, but actually we need to turbocharge it and really focus on doing that. And so at the start of the pandemic, a third of the wages in this borough paid less than real living wage. Unemployment was rising and the demand for housing was increasing. So actually, in terms of building back better, building back fairer, it was even more urgent, and the urgency was even more important. Applying Sir Michael Marmot's principles and the 6 pillars alongside our anchor institutions, the deal had given us that partnership with the NHS, with the CCG, with our local providers, and developing with the voluntary sector. Over the last few years, we've given a community investment fund of over £12 million to community groups to develop that community capacity. So the relationships with the community groups, and what it gave us was a huge potential for us as anchor institutions. I think talking about the council itself, we indicated that if we could purchase 10% more goods and services within Wigan Borough than we did, then we could stimulate £30 million to the local economy. And of course, it's not just £30 million, is it? Because if that £30 million for goods and services from local businesses is creating employment, then people are getting into work, people are receiving wages, they are spending their money locally, so there's an accumulator effect. Now think about if the NHS, schools, colleges, university, the council, the police, the fire service, if all the public sector services, which spend well over £1 billion a year in this borough, devoted more of their time to local business and local provision, then that could have a significant impact on the local economy. But it's not just the procurement of goods and services, is it? Because actually, all these public sector bodies also own land, provide employment, and the opportunities to utilise land to deal with the housing issues, the opportunity to provide employment, and also for within our goods and procuring of services to look at social value and increasing social value so that we commission and serve with ethical providers and ethical suppliers who meet our aims and objectives and agree to that. So working individually and collectively as partners on different projects at the moment to boost economic, social, health and education prospects for local communities is really important. So if we move on to the next slide, please. So as I said, prior to COVID-19, a third of borough's jobs paid below the real living wage. Our wages were the 4th lowest in the country. And over recent years, average earnings have been falling. Lee, which is the area that I represent in the borough, Lee was identified as the worst in England for social mobility in early years. 33 areas of the borough were in the top 10% of most deprived, which is up from 2015. And COVID's made it worse. So it is really important. It's clear that the current economic model is not working for the citizens of this borough. And whilst the deal has brought about some improvement in health and wellbeing and opportunities and partnership working, then moving back to business as usual is not an option for us. And so, yes, as Paul Dennett was saying, we have that role of lobbying nationally, lobbying regionally, but actually this is about what can we do in Wigan and how can we contribute and maximise the benefit we can get. So if you move on to the next slide, please. So in practice, commissioning creatively through ethical frameworks, not just the council, but the NHS and all those partners, the schools, the colleges, using ethical frameworks to support the growth of local suppliers. And as part of the community wealth building process, we have a business consortium. And of course, what they were saying was they were very desperate to get more contracts and more tenders from local authority and the public sector. But actually, there's an issue about them procuring their goods and services from other local businesses. It's not just coming to the public sector to get more contracts. So that we've developed this approach around ethical frameworks and supporting that. And working collaboratively during the pandemic to attract residents seeking employment. And what we found is working with WWL, Wigan Wrightington and Lee NHS Trust, big vacancy and difficulties in getting staff for health and social care. And actually what we've done through the pandemic is we saw nearly 1,000 people come forward to volunteer who had not previously volunteered in the community. And so part of what we're doing is enhancing and ensuring that that volunteering capacity still retains. But what it did do is create new job opportunities for people. In health and social care, we found that a number of people who were furloughed or lost their jobs in hospitality industry has a lot of transferable skills to health and social care. And so some of our demands and additional pressures that were being put on us, the opportunities to do that. And interestingly enough, with the leisure centres being shut, a lot of the leisure services staff volunteered to be redeployed into health and social care. And that's brought about two benefits. One is that those leisure staff are now finding that they actually want to work in health and social care and are moving across. But the other thing was they brought an absolutely different perspective to caring for people in care homes, supported housing and home care. They brought a different aspect about active living and exercise, and so brought a different approach. And so the collaborative partnership that we've developed between the council, Wigan and Lee College, Edgehill University, our hospitals and primary care are about developing career pathways for students, for opportunities, because I envisage, and so to some of the government documents on integrated systems talks about one workforce for health and social care. And so I just think locally, working with the colleges, working with the care sector, with the hospital, actually to create a career pathway where somebody can leave school or college, go into health and social care, maybe even at home care level, but have a direction and a career pathway that can take them right through a range of health and social care experience. So the person who goes to work as a home carer today could be the chief executive of the hospital trust or the director of nursing, because there is a clear pathway within our authority or within our area to do that. And primary care, working closely with GPs, additional roles are employed as part of the wider health improvement team, and effectively targeting those most likely to experience health inequalities. It's about, we know it's about targeting those areas of deprivation and those areas where we know that people have significant health inequalities. And we've got young people at Wigan and Leigh College leading on communication and engagement and focusing on providing high quality homes to meet housing need. As I said, we've had a significant increase in housing demand and people on the waiting list, and actually looking at ways of meeting some of the housing need in a way that builds on community wealth and community health is really important. So thank you. If you have the next slide, please. So I think that was it. So generally, the approach we're taking is a personal approach to Wigan, but follows the principles that Paul Dennett outlined in Salford, who were doing it in their way. And I've always said that you can never recreate the Wigan deal or community wealth building in your area, but what you can embed are the principles. And I think that's what's seen from Salford, what we're seeing from Wigan, that the principles and the direction of travel are being done in its own way, unique to that area, and responding to the assets that exist within that area. So thank you, Cash.
And Keith, actually, I was going to summarize it, and you just did that at the end there. So yes, absolutely, the Wigan deal is absolutely the right thing for Wigan to do, and the way you developed it and the way you're now evolving it and implementing it are the Wigan way of doing things. And quite often we set ourselves off saying, no, let's do what they've done and try and copy it. And that immediately, going back to Paul's bit about, you know, that nothing about me without me, that banner that was in the presentation, actually doesn't always work, does it? So we're just shifting the slides around because Sir Michael has joined us. So thank you, Keith. That was fantastic. Thank you for sharing everything that you have been doing. And actually, another key theme that came out of your piece was around the creativity piece, around actually, you know, how can you get creative, but also keep an eye on the real local issues? And actually, what does a good day look like for me? I think that's a really important question that we should be asking everybody. And working with your team around the workforce culture, there's two words in there that I always look back to, which is courageous and accountable. How can you remain courageous and accountable for what you're doing? So thank you so much. Okay, so next we have Sir Michael Marmot, and actually, I'm lucky, actually. This is my third event that I'm chairing with Sir Michael present. He's spoken eloquently in the past about the challenges that have faced us. And last time, if you remember, he said, okay, well, if you get on and do some things, invite me back and I'll listen. And we're back here again. So Sir Michael, great to see you. Just a brief introduction around Sir Michael. So he's a professor of epidemiology at University College London and director of the UCL Institute of Health Equity, and a past president of the World Medical Association. He's also a thought leader and has written several books. And among his many accolades, I've underlined this one, in 2021, Professor Marmot received the BMJ's Outstanding Contribution to Health Award. So very well done on that. So without further ado, I will hand you the mic, the slide deck, and absorb. I'll get my note paper out and we'll have a conversation afterwards. Thank you very much.
Thank you. And I think it's a statement of something that I didn't get my presentation to you in time for you to make it part of the master slide deck, and B, that my first slide, apart from this, is based on something that I got this morning. I was delighted to have the invitation, less delighted to talk to you, because I thought there are two possibilities. You know, one is, if you haven't heard what my message, then that's not very encouraging. You haven't been listening. As you said, this is my third visit. The second is you have heard it before, in which case you won't be all that interested. I was thinking that when I got an email this morning from Gothenburg in Sweden, 18th of November, Gothenburg has now been appointed as a UNESCO City of Literature. And the email from somebody who works for Gothenburg City Council in Sweden said, "You are part of our city's journey." And he translated from the website, "For most people, Gothenburg is a good city to grow up in and live in, but at the same time, there are big differences in living conditions between Gothenburgers and between different parts of the city. At the City of Gothenburg's first Equality conference in 2014, we received advice from public health experts, Michael Marmot. Do you want to do more to reduce the gaps in the city? Read to your children." In fact, when I visited Gothenburg on a subsequent visit, they told me that at the airport, Gothenburg had a sign saying, "Gothenburg, a good place to do business." And Peter Molen and his colleagues in the city council were trying to get that sign replaced to "Gothenburg, read to your children." And now he wrote to me with great pleasure saying, "You're part of our city's journey. We're now the UNESCO City of Literature." And forgive this immodesty, but I'm delighted that sometimes people listen, and it really does make a difference. So I'm really pleased. When I talked to you previously, it was before we published Health Equity in England, the Marmot Review 10 years on. I came in person to Manchester, to Chester. And then we published the 10 years on review, which was looking back at what had happened in the 10 years since the Marmot Review, Fair Society, Healthy Lives. We'd made a series of evidence-based recommendations on what we could do to reduce health inequalities, to advance the cause of health equity. And literally on the 10-year anniversary, February 2020, just before the pandemic crashed upon us, we published this. Life expectancy had been improving about 1 year every 4 years for women and for men. And then in 2010-11, the rate of improvement slowed dramatically. I had been saying I was cautious in attributing that to government policies. But in fact, subsequent analyses showed that the greater the cutback in public expenditure regionally, the worse the health improvement. So that was a marked slowdown. And we pointed to this phenomenon, which is highly relevant to today's meeting. This is women, the least deprived, 10%. These are regions of the country. There's very little regional difference. If you're rich, it doesn't much matter which part of the country you live in. The regional differences are small, and life expectancy was improving a bit in each region. If you're in the most deprived 10%, it matters enormously where you live. There are big regional differences. Life expectancy for the poorest 10% was going up in London and going down in virtually every region outside London. So not only were the inequalities getting bigger, there was a big regional dimension to the growth in inequalities. And let me show this in more detail. This is the Northeast, but it would look very similar for the Northwest. Here's London. For the least deprived 10%, there's essentially no difference in life expectancy between London and the Northeast. And then the greater the deprivation, the greater the disadvantage of living in the Northeast compared with London. And as I said, that would be very similar for the Northwest. Or to put it another way, if you're in the Northeast, the disadvantage of the health disadvantage of being in deprivation increases. Now that's really interesting. This is a national index of multiple deprivation. Clearly it applies everywhere. The more deprived, the shorter the life expectancy, but it applies more in the North, the Northeast and the Northwest. Really, we need to understand that. What is it about being in the Northeast or the Northwest that means the health consequences of deprivation are greater? And then the dotted line is life expectancy in 2010-12, the solid line 2016-18. And you can see for London, it improved across the deprivation spectrum. But in the Northeast, it declined in the poorest 10%, declined in the second poorest 10%, and then really no change for the bottom half. It's only till you get up here that you get some improvement. So that's the context. That's what happened post-2010. I'm not a negative person, but if you were negative, you could say that the government's saying, my gosh, we did this, we created a bigger gap, now we need to level up and redress some of the problems we caused. And we're working with Cheshire and Merseyside, as well as Greater Manchester, as well as Lancashire and Cumbria. And I'm just amazed that we see these gradients everywhere. There's the index of multiple deprivation. And here are the local authorities of Cheshire and Merseyside, just ranged across the deprivation spectrum and life expectancy. So for women in Cheshire West and Chester, life expectancy 84. In Liverpool, it's 80 and a bit. For men in Liverpool, 70, just under 77, 76.6. And in Cheshire West and Chester, 80.3. We see the social gradient. In my 2010 review, we had 6 domains of recommendations: give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. So what happened in 2010? The government had as ambition austerity, rolling back of the state. In 2009-10, public sector expenditure was 42% of GDP. And they were as good as their word. They really did cut back public expenditure. By 2018-19, that 42% had become 35%. In my 2010 review, we coined the phrase proportionate universalism. Because of the social gradient, we should want universalist policies. In fact, you could almost call proportionate universalism leveling up. I didn't, but you could. Here's the social gradient. Let's say that's less deprivation, life expectancy. If you focus only on the poorest, good for the poorest, but you miss the rest of the social gradient. So we said we should want universalist policies with effort proportionate to need. And you know what we got. This is spending by local government per person. In the least deprived 20%, their spending went down by 16%, and the greater the deprivation, the greater the reduction. In the most deprived, it went down by 32%. spending on adult social care, crisis in adult social care. How did that come about? Well, I'll tell you how it came about. The reduction in spending per person on adult social care in the least deprived 20% went down by 3%. In the most deprived, it went down by 16%. We said effort proportionate to need. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Could that have played a role in the slowdown in improvement in health and the increase in inequalities and the decline in health in the poorest 10%? Yeah, I think it could. So what happened? I won't go through all of my recommendations. Child poverty, defined as living in a household at less than 60% median income. Pre-housing costs in 2010-11 was 18%. After housing costs, 27%. And over the decade, that 27% rose to 30%. How did that come about? If you look at change in net household income due to tax and benefit reforms post-2010, let's look at working age families with children by household income. If you were in the poorest 10% of household income, your household income would go down by 20%. As a result of changes to the tax and benefit system. In the second poorest 10%, down by 12%, and then the richer you were, the less the reduction. Some reduction up here, but nowhere near as big as the reduction down there. And this is really very important because the whole thrust of working with Greater Manchester, of working with Cheshire and Merseyside, of working with Lancashire, South Cumbria, and now North Cumbria, is that much can be done at city and regional level and local level. But this sets the context. The Chancellor, the Minister of Finance, has in his hands the lever that can change child poverty overnight. And we know he can do it overnight because a month ago, between Wednesday and Thursday, he took the decision that predictably would put 300,000 extra children into poverty. He cancelled the upgrade to universal credit. If he can increase child poverty between Wednesday and Thursday, between Thursday and Friday, he could reduce child poverty. In fact, he took £6 billion out of universal credit, and then in his budget, he put £2 billion back. I'm not good at sums, but I think that's still minus 4 billion, which is a lot of money to take away from people who are at risk of going into poverty. And then, of course, there was cutback in services. And perhaps because of that cutback, after a small dip, violence increased. And it follows the social gradient. The less the deprivation, the lower the violence rates. And then came the pandemic. That was all pre-pandemic. And then came the pandemic. I waited 10 years to do my 10-year follow-up. I waited 10 months to do the COVID-19 Marmot review. Here's the social gradient in mortality from all causes. And here's the social gradient in mortality from COVID-19. It's almost exactly parallel to the social gradient in health more generally. You probably heard the health secretary say it's a race between the virus and vaccine. You can't believe it's that simple, surely. This is not just about vaccination. The causes of inequalities in health are similar to the causes of inequalities in COVID-19. It's the conditions in which you're born grow, live, work, and age, the social determinants of health. Yes, we have to control the virus, but we also have to pay attention to the causes of health inequalities. And here, Cheshire and Merseyside, the gradient in COVID-19 mortality. It's remarkable how consistently these gradients are seen. And when we compare with the England and Wales baseline, this is Lancashire and South Cumbria, we see very similar social gradients. I said we're working in different regions. And again, isn't it remarkable? We go to another region and we find this relation with deprivation that's a gradient. Looking Greater Manchester, age standardized COVID-19 mortality, 25% higher than the England average. If we look at public health spending reduction in real terms in pounds per person, Northeast, West Midlands, this is the England average, Northwest. Now, my view of public health is it's much broader than the professional public health people, my colleagues, do. It's about my 6 domains: early childhood education, work, environment, and so on. But it's much harder to do that if the spend per person has gone down for the Northwest by £15. And then we look at what happened, the management of the pandemic. One way of looking at that is excess mortality. In other words, in comparing countries, we don't ask just how does the COVID-19 mortality compare. We look at the excess, how many extra deaths there were based on the prediction of the previous 5 years. And in 2020, the excess mortality in the UK was higher than in any other country. Over the whole pandemic, the US is now the highest, its rightful place, given how appallingly they managed the pandemic through the whole of 2020. But we're right up there with high excess mortality. And in fact, there's a general relation. The worse the improvement in healthy life expectancy in the decade before the pandemic, the bigger the excess mortality during the pandemic. So the US had a decline in healthy life expectancy in the decade before the pandemic and a big excess mortality during the pandemic. We had very slow improvement in healthy life expectancy and a big excess during the pandemic. Denmark, Latvia did quite well in improvement in healthy life expectancy pre-pandemic and actually had negative excess. They were doing better in 2020 than you would have predicted from the previous 5 years. We declared Freedom Day on the 19th of July, and guess what? The cases, initially there was a peak, which was probably something to do with the Euros, went down, and then of course went up. And we're right up there. The US is now doing better. When the House of Commons published their report on how badly we'd managed, they said, well, it was a game of 2 halves. The first half we were doing very poorly, but then with the vaccine, we're doing brilliantly. Whereas countries like Taiwan and Japan and South Korea that did very well in the first half, not doing so well now. What? What? Can you see Taiwan? There's Taiwan. Can you see any cases? Hong Kong, Japan, South Korea? very low level. They're still doing very well. When Australia had a few cases, they had a complete lockdown. When we had 45,000 cases on a single day, we declared Freedom Day. So we're still not managing very well. And the idea that it was a trade-off between the economy and the virus was just wrong, completely wrong. Economic decline in the second quarter of 2020 versus the rate of confirmed deaths due to COVID-19. So there's Peru with high mortality from COVID, and GDP growth from the previous year was minus 30%. There's us, the United Kingdom, very high confirmed death rate from COVID-19 and a big economic hit. There's Taiwan, the one that's supposed to be doing badly, with a low death rate and a much smaller economic hit. In fact, this is not a trade-off. Control the virus well, and you have less of a hit to your economy. So what's going on here? I think of health as a measure of societal success. Pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries. And then during the pandemic, we had the highest excess mortality. And I think the link could work at 4 levels: poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, which was done in a most regressive way, and we weren't very healthy. And it doesn't have to be this way. Child poverty, measured slightly differently. There's the United Kingdom, there's the United States, Denmark, Iceland, Norway, Finland, the Republic of Korea, Cyprus, the Netherlands. Child poverty at 9, 10, 11, 12%. By this measure, we were 20%, the United States was 29%. And as I said a few minutes ago, that's within the purview of the Chancellor. He could reduce child poverty if he wanted to. He chose to increase it, but he could have chosen to reduce it. Public spending on early child education and care. US dollars adjusting for purchasing power. Luxembourg, Iceland, Norway, Sweden, Denmark. This is the OECD average. As usual, we're worse than the average of rich countries. There's the United States. What's going on here? There's Norway, let's say, and there's the United States. Norway chooses to spend $12,000, $13,000 adjusting for purchasing power on young children in early child education and care. And the United States chooses to spend less than $4,000. And we're more like the US than Norway. This is a political choice. Do we think it's important or not? It'll, like my colleagues in Gothenburg, it'll affect children. There's Sweden. And universal credit is worth less than 1/5 of average earnings, even with the uplift. Standard rate unemployment benefits for a single person as a percentage of previous earnings. Denmark, 90%, Sweden, 80%, Italy, 75%, Netherlands, the UK with the £20 uplift, 18%, of previous earnings for a single person, 14% with the uplift removed. Wow. We're miserly in terms of the benefits we give to people who need it. Does that matter? Well, yeah, it might. That might be why we're not doing well in terms of health. I got the nurses in Northern Ireland to work on this, what nurses can do to tackle the social determinants of health. So I've been talking about government policy, but we can get integrated care systems involved as well. And then, as I'm sure you're aware, in June, on the 30th of June, we published our Build Back Fairer in Greater Manchester report, Health Equity and Dignified Lives. The front page of The Guardian on the 30th of June had two stories, England 2, Germany 0. Jaw-dropping fall in life expectancy in poor areas. That cliche was mine, unfortunately. I sent this front page to a colleague in the US, and he said he thought both headlines were jaw-dropping. This is the fall in life expectancy in England in 2020. 1.3 years fall in men, 0.9 years in women, and in the Northwest, 1.6 years in men, 1.2 years in women. This is what I described as jaw-dropping. And we had a Build Back Fairer framework for Greater Manchester. And it looks like our 2010 recommendations: early years, children and young people, housing, transport and the environment, communities and places, public health, work and employment, income, poverty and debt, and then these 6 spokes, which we think are important. Build back fairer for future generations, build back fair resources, build back fairer standards, build back fairer institutions, and we heard in the previous presentation about anchor institution approaches, and the role of business, monitoring and accountability, and greater local power and control. As we build back fairer, we do need to pay attention to early child development, to education, to fair employment and good work for all, to making sure everyone has at least the minimum income necessary for healthy living, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But we also need to address poor governance and political culture, the increasing social and economic inequalities. It's not enough to say austerity is over. We need to reverse the reduction in spending on public services. And we weren't very healthy coming into the pandemic. My argument is we need to put a fair distribution of health and well-being at the heart of all government policy. Thank you.
Well, thank you again. And yeah, again, you've seen Chris there giving you a round of applause. Thanks, Chris. Okay, where are we now? I think that's the question. Last time you were here, we felt in a pretty similar position, actually. This everything you've shared with us. Yes, it's there, isn't it? You can't ignore it. Has anyone got any reflections people would like to share? But yeah, I just want to, before we do that, just want to say a huge thank you again for joining us in the Northwest and for hitting us with the data. I think that's how I think it is. It's giving us 2 barrels, but actually we expected that. We knew that was going to come. And the other question is, and what we're going to do about it? I guess that's the question that's in my mind. So, any reflections colleagues want to share while Sir Michael is with us?
Can I have a reflection? I just glanced at the chat. I'm not good at multitasking.
It's okay.
So I wasn't looking at the chat while I was talking, but somebody put in the chat, Esther Hindley, said there could be forceful lobbying from all Marmot areas together. And if I had, I've in the past, one or two of you have heard me talk about the fact that I inhabit fantasy land. And in my fantasy land, we would get all the Marmot areas, and we get all small areas, large areas, regions of the country saying, we're going to do this. And central government will look silly having fallen behind, because every region in the country will all be marching off in a particular direction. So I really, really like the idea of getting the different Marmot areas, regions together and saying we are a powerful voice for doing things differently. And if, to come back to my reflection on good governance, I don't think there's anybody in any political party at the moment that could say that what's happened in the last couple of weeks looks like a model of good governance.
Thank you. Dominic, you've put your hand up, so I'm going to invite you in.
Thank you, Cash. I just want to say I completely agree with that suggestion Michael's just made. And I actually think if we had a kind of bottom-up manifesto of action that we could sign up to both professionally as systems and politically, I think that would be extremely powerful and would help consolidate the kind of social movement aspect of what we're trying to do. But the comment I just wanted to make is that Michael showed some slides around the impact on life expectancy. And of course that, because of the way life expectancy is calculated, that is going to get much worse this year. And probably will have a long tail, because what we know is we've got longer waiting lists, more people with long COVID, increased escalations of critical clinical conditions such as high blood pressure that have not yet been diagnosed. All of those things are going to create a very long shadow of the pandemic in our regions, particularly for those who are on lowest income and most vulnerable. So I think that point is extremely powerful, and we are going to have to try and address that long pandemic tail almost as a separate issue to the broader social determinants. So it's, in a sense, it's a double whammy for us. We've got more risk, but we've actually got more need now. And so we need to think of ways in which we might manage that more effectively.
Thanks, Dominic. Any reflections?
I'm in sort of technical nerdish terms, I'm really interested in the off diagonals. I'm really interested in the deprived communities that are doing better than you would have predicted from the level of deprivation. And that's really interesting and important. And indeed, in our work, when we had a kickoff of the Health Equity Commission in Lancashire, and it was then South Cumbria, North Cumbria said they wanted to join. And we had our first meeting of the commission just recently, a few days ago, but we had a sort of preliminary meeting a few weeks ago. And I was really inspired. I didn't hear one voice saying, oh, it's all too depressing and there's nothing we can do. Nobody said that. It was all, wow, this is how we're going to take action. This is how we're going to improve things. So I'm saying that deprivation is not destiny, and national policy, important as it is, and I've tried to say it's very important, isn't everything. There's a great deal we can do locally and regionally. So those off diagonals are really interesting.
What's been really interesting about today has been the actual action that people have taken. So last time we were together, there was, very similar, but we were not able to mine the action as much as we have this time. And just reflecting back on that, we've seen from Dominic's work, a really strong data-led approach, and thinking about some of the reasoning behind some of the things happening. Jane, your presentation was very much about that strategic intelligence, and I'm guessing that you've got all of what Sir Michael has shared today to help you, with the waterfall, the analogy that you used earlier on. And then we heard from Salford and Wigan about actually what they're doing, and the thing that keeps coming out for just looking at the notes that I've made here is around, there's a load of agency here. So there's, okay, we know this, but what are we going to do with it next? And going back to your question, where are the deprived, where is this making a difference? Where are the green shoots? I think there'll probably be a relationship between local leaders who basically, like we have had today, have taken action, they've taken agency, they've connected, they've built relationships, because they see the system, they see everything, but they see their role within it. And I think that's an important point to think about. So yeah, I don't know what you think of that, but also, where are the green shoots? I think that's a question that I just want to put to all the speakers that have been here today. Are there any green shoots? Are we seeing anything that we think, oh, that's a bit interesting? So maybe, Sir Michael, I'll come to you first for any kind of initial reflections, and then invite the other colleagues in to see whether there are potentially things that we could be looking at more.
Well, yeah, I will comment, and then I'll apologize and leave. I started the day in Gothenburg, and now I've got to go to Denmark. This lockdown business is nonsense. So I do everything from my desk in London. So I'll comment and then leave. Yes, there are. Andy Burnham was delighted in our 10 years on report that we showed that children eligible for free school meals in Greater Manchester were doing worse in terms of early child development than children eligible for free school meals nationally. And in 3 years, that gap closed. That gap closed. Now, the poor kids still do worse than the average, but the poor kids in Manchester were doing worse than poor kids nationally. And they weren't anymore in 3 years. It means concerted action, concerted paying attention to these issues. And I was struck, I was looking at the data from Cumbria, that the children eligible for free school meals in the richest part of Lancashire and Cumbria were doing worse than in Blackburn with Darwin. That's really interesting. Poor kids are doing better in terms of early child development in poor areas than they are in richer areas. Hey, that's really interesting. What's going on here? Is it because if you're a poor kid in a richer area, everybody leaps past you, they're better dressed and they've got computers at home and goodness knows what, and you don't, and you feel socially isolated? Or is it that teachers and others in poor areas really focus on the poor kids because there's so many of them? That's their core job. Well, that's really interesting. And we think early child development is fundamental to what happens in education and throughout the lifespan. But whatever the answer, it's urgent to find that out. You asked about green shoots. That's really interesting, that you can break the link between deprivation and poor early child development. And understanding how that link got broken and how to build on it seems to me is really important. And we can point to issues like this through the life course. And then, if you'll forgive me, I need to scoot off.
Thank you so much, Sir Michael, for your time, and yeah, all best wishes from us. And yeah, we look forward to talking to you again soon. Yeah, safe travels. Thank you so much again.
Thank you.
Okay, panel. Any reflections? Dominic, I don't know if there's anything additional. Jane, again, there's lots there. I don't know whether you want to start with a reflection.
Well, I think, sorry, go on, Jane.
Just in relation to that last point about green shoots, I think there's a case study that was with the 10 years on report that highlighted some of the key areas where Greater Manchester was kind of making a difference, and positive action was making a difference, and school readiness is was our top one, but also things around some of the work we've done with the long-term unemployed, and also I just mentioned some of the stuff around kind of smoking and tobacco. And there is a lot to be learned from the approaches that we've taken to reduce those inequalities, and even some of the work we've done in the vaccination programme during the pandemic, and how we've reached people in a way that we've never done before, and we've worked at a scale and pace we've never done before. So I think there's lots to celebrate in the way that we've approached some of the work. And again, Paul and Keith gave some brilliant examples of where we are really making headway. But there is still so much to do. The challenge is massive, and it's how we build on the good work and go further and faster, really.
Thanks, Jane. Really, really good reflections, and yeah, builds on everything that we're doing. And I've asked the question very deliberately because what I don't want to do in sharing today is leave you on the floor with all of this really important data, but also give you some hope for the future, give you some examples of things that you can hold on to and do. Okay, Paul, I think we just want to come to you because, again, you shared some real practical work you've been doing in Salford, and just want to hear from you now that you've heard Sir Michael speak.
Yeah, no, I mean, the work of Sir Michael is well known, and obviously 10 years on, we know things have actually worsened. And, you know, I really like the international comparative dimension of Sir Michael's work, because I think it helps to put things into perspective here. I mean, clearly, some of the changes we need to see more progression on this agenda are changes at a national government level, changes in legislation, changes in resource allocation, and, you know, genuinely taking levelling up and, you know, building back better seriously, and demonstrating that not just through, you know, splurges of capital here and there and, you know, a tokenistic agenda, but a new way of doing things. And I think, you know, levelling up and real devolution offers us huge opportunities. And, you know, even over those 10, 11 years of austerity and cuts, I think, you know, when we reflect on the work of Greater Manchester and certainly the work here in Salford, you know, I think we're in a great place to capitalise on all of that. We've got the partnerships, we've got the vision, the strategy, and what we now need to do is be genuinely empowered to really accelerate much of this really innovative work we've been doing over the last few years. But I am a realist at the end of the day, and, you know, I'm often reminded that, you know, over 220 million has been taken out of our own budget here in the City Council of Salford, and there's huge challenges moving forward. There's a massive amount of uncertainty around local government financing. The use of regressive taxation only exacerbates poverty and inequality. So, you know, there are some real macroeconomic structural issues which are very tricky that we just need some more traction on. And, you know, I would say that probably we won't get that with the current government, and we'll need a change of government to deliver on some of that, because it is a very different way of running the economy for the many and not the few. But you know, I think Sir Michael's work helps remind us all of the absolute importance of this work, and not to give up hope, really, because I think, you know, we can always find reasons, I think, for not doing stuff or pointing to how dire things are. But actually, you know, what gets me out of bed in the morning is just working through the complexity, delivering outcomes, improving what we're doing here in the city of Salford, and making sure that everything we do is about people. You know, the work of the Poverty Truth Commission reminds me daily that, you know, if we're doing something, we've got to do it with people, if it's to be for people, and if it's to genuinely deliver real meaningful outcomes. But yeah, we're in a really strong position, I think, in Greater Manchester. We need government to work with us now through levelling up. You know, the spending review and budget announcements were seemingly slightly more positive than we anticipated, but for me, we're still very much on a journey of delivering levelling up for the North, for Greater Manchester and for Salford. Yeah. So thanks.
Thanks, Paul. Dominic, any reflections from you? I know you've got your hand up as well, and you put a comment in, so I was coming to you next. So
all right.
Anything else, Shane?
Yeah, well, just I wanted to pick up on Jane's comment and on what Paul just said. During the pandemic, of course, one of the things all of us did was set up neighbourhood hubs or hubs within local authorities to try and support people, particularly with self-isolation, or, you know, if they were self-isolating, support with shopping and things. Now, one of the bits of learning from that for us was, as we contacted people through our local tracing system, what was clear was the people who needed help were the people who had multiple pre-existing social challenges and economic challenges. And they needed help almost not because they'd got COVID and had to self-isolate, but because they'd entered that state with massive need already. And one of the characteristics of the help that they needed is that they were socially disconnected. In other words, they hadn't got family, friends, neighbours they could rely on to give them the kind of support that, you know, we were offering. And what we uncovered was really a cohort of the population who weren't particularly welfare dependent, but were extremely vulnerable. You know, single parents with a number of kids and things. And I think we learned through the pandemic that actually offering a kind of wraparound, you know, debt advice, employment advice, learning advice, practical help with, you know, whilst they were self-isolating with shopping and things, but almost as if what the pandemic did was stick some red flags down into vulnerable communities and say, whatever you've been doing, it hasn't really been enough to support this population. And many of them had part-time jobs, you know, so this was not a non-working community. So we have tried to reflect on that and think more about how the kind of stuff we were offering during the pandemic, or still are offering in terms of help hubs, might be more universalized as a whole person, whole household, whole family offer that joins up public services at the neighbourhood level. And to me, I think this is something about, you know, the ways in which we mobilise our leisure and wellbeing services, our neighbourhood services, and learn from what we did during the pandemic has some real opportunities. You know, if we're thinking about what is it we can do within existing capacity, but do differently, that would increase the resilience of our most vulnerable populations.
Thanks, Dominic. And actually, Keith and Paul answered some of those questions. You know, what does a good day look like? You know, nothing about me without me. Really, you know, those are the messages that we're filtering through. Now, we're really keen at the collaborative to not lose this opportunity to learn. And in a second, the team are going to put a link in the chat that I would love for you to participate in. We often put these sessions together, and you know, we want to learn as much as we can from your experience, and actually, you know, build on what we're doing. Because actually, if you look back last year when we did the same workshop or similar, we've actually built on it by bringing some real examples in, and we had some examples then. So it's almost, how do we make it even better? How do we, you know, share this learning more wider so that you can have even better conversations with some of the people that you're talking to? And certainly at Northwest Employers, we have a few opportunities to do that through some of our work, and as do the other partners, but we can't do it as well if we don't hear back from you around, you know, how did this land? What could have been better or different? I'm also mindful it is 12:30 right now, and I did say the session ends at 12:30. So thank you to everybody who made the time to turn up. Just want to say a huge thank you to all the speakers. You did brilliant. You did a wonderful job. And yeah, you've inspired us to do and try things a bit different. And actually, you know, looking through my sort of summary notes, if you like, you know, everything that you've described is data-led. It's about how do we turn that data into intelligence, and how do we give that intelligence to the right people on the front line, say, actually, what you're doing is right. Here's some evidence. Now continue doing it, or stop doing that. That's not working. That's making it worse. Try this, and actually have the courage. Going back to the Wigan stuff, the courage to have the right conversation. So hopefully you found today useful. Hopefully you're taking some power away from today, because again, we were talking about power sharing. Please take the power that belongs to you. See your role in the system and own it, and actually have the agency to, you know, make those green shoots come to life, because actually that's where some of the secrets are. It's about going in and doing the actual work, not, you know, one size fits all. We know one size fits all doesn't always work. So hopefully you found today useful. It is my last masterclass, and I just want to say a big thanks to the team all the people that have been behind the scenes, pulling the strings, making sure that we run to time. Thank you very much and have a great day. Have a great week.